And today I will be sharing that with Patricia Maiso, also which was one of the investigators in our department in the institute. And today the topic today is dedicated to, well, we will have the first talk with Elena Zamagni, focusing on imaging in myeloma, and then we will have several talks about novel therapies and novel pathogenetic pathways in multiple myeloma, how we are trying to target the myeloma plasma cells in the clinics, really, and from the lab to the clinics. And at the end, we will have the keynote lecture of Dr. Kenneth Anderson, searching of the Achilles heels of multiple myeloma. So with that, I think we can start. And the first topic, as I said, the first one would be Elena Zamagni from the University of Bologna in Italy, to speak about well, how we are now addressing the topic of the imaging and the bone lesions and the imaging of the tumor burden in multiple myeloma. So thank you very much, Elena.
So thank you very much. This is really my love, imaging in multiple myeloma. And I think I'm lucky because I've always been fond of, but I think that in the last 10 years, we have reached very important steps in this field. Because to my opinion, imaging in myeloma went from a sort of picture of the disease. We have always have to deal with bone lesions in multiple myeloma. They are one of the Raab symptoms of myeloma. So of course, the picture of these bone lesions was very important. But I think that nowadays, imaging is more and more becoming important for risk assessment. So we need imaging from the very early phases, MGUS and smoldering myeloma, where we need from one side to exclude the presence of bone disease, but at the same time also to predict the risk of progression. And we need imaging in overt multiple myeloma. Yes, we still need imaging to assess bone disease and bone stability. So from one point of view, to make a picture of what has already happened there. So what are the damage, the destruction that the disease induced in the patient. But I think most importantly nowadays, we have to assess the risk. So the tumor burden, the eventual presence of high-risk disease, so extramedullary disease, and last but not least, to assess the response to therapy. So we were used to have a whole body X-ray. Whole body X-ray now has been abandoned. It has been abandoned because it was underestimating bone disease. So it was not making the correct picture. Simply, we want to change and have a newer machine making a better, more sensitive picture, but also is not able to perform the last topics. So to assess tumor burden and to assess response to therapy. So all the newer imaging techniques referred to whole body X-ray resulted superior. So this is the reason why nowadays we are suggesting whole body X-ray only for specific complications, so fracture or something similar, or when really nothing else is available. Otherwise, we may use as morphological imaging techniques, the CT, so usually it is low dose CT because this is sparing for, of course, radiation and time also. It can be the CT part of PET CT, or we can use functional techniques. So in this sense, we have PET CT and MRI. We should be careful that MRI and PET CT that are often considered interchangeable. So in my presentation, I will tell you that we can use one or the other, are looking at different things. So PET CT, of course, there is the CT part evaluating the damage that already happened, and there is the PET part evaluating disease metabolism, while MRI is assessing bone marrow infiltration. So they are different. So sometimes to mix one with the other, it's not really optimal. We can alternate the use if there are doubt results, or if we are not sure about something, but to perform a diagnosis, one picture, and then after treatment, another picture, to my opinion, is not really optimal. So we are using imaging techniques each time we have to make a staging of the disease. So of course, a diagnosis, baseline, but each time also we would like to restage. So at the relapse, usually we are making again another picture of the disease. And in this sense, we are using imaging. But as I said, we use also after treatment nowadays, and this is recommended by the International Myeloma Working Group to establish the true response after therapy. So just one slide going on early phases. We have two goals in early phases. So in smoldering multiple myeloma, we have to exclude bone damage. And in this sense, two studies, one with PET-CT and one with whole body low-dose CT, clearly demonstrated that if we are using less sensitive technique, whole body X-ray, we are misdiagnosing 25% of the patients. So we need to use whole body low-dose CT in smoldering multiple myeloma to exclude that bone damage has already happened. This is the first part. Then we want to assess the risk of progression. And for this, we have whole body MRI. And once again, within the International Myeloma Working Group, it was demonstrated that patients carrying more than one focal lesion are at that high risk of progression into overt multiple myeloma in 2 years that we should treat them. And this is one of the new biomarker of progression that is used, or slim crab that is used to treat the patients. So on overt multiple myeloma, I told you that nowadays we would like at the same time to make a picture and to make a prognostication of the disease and to evaluate the response to therapy. So to this goal, PET-CT is particularly favorable because in one exam, it has the two parts, the CT part, which is depicting the lytic lesion, and the PET part, which is usually performed by FDG, which is assessing tumor burden. So with this technique, one exam, you are picking 2 points. We are using and suggesting this technique usually to intercept the eventual presence of extramedullary disease. So with one technique, we can also have a prognostic picture of the disease. We know that patients carrying a lot of focal lesion and carrying a high metabolism by FDG are at worst prognosis. But of course, for sure, the worst prognosis is belonging to patients carrying extramedullary disease. By FDG, not all the patients are positive at diagnosis. So one should recall this, that there is 10 to 15% of patients either falsely negative, and we will see this in a moment, or truly negative, because the tumor has a very, very, very low metabolism. Of course, you can rely on the CT part in these cases, or you may change of technique. So those are the cases when the FDG PET-CT is negative, when you may perform a whole body MRI, and we also will see this in a moment. So if we are suspecting extramedullary disease, for sure PET-CT is the suggested technique. The prognostic value of PET-CT by FDG is also staying in the era of novel combinations. So this is DARA-VTD, the Cassiopeia trial. So you can see here that the prognostic significance of PET is staying also in this newer setting of patients. So why I said that it is important to identify extramedullary disease? Because first of all, we should truly differentiate patients carrying bone-related plasmacytomas, that are the patient truly having, soft tissue plasmacytoma, truly having extramedullary disease, differentiating from patients with bone-related or paraskeletal plasmacytomas, because the prognosis and the incidence is completely different. So true soft tissue plasmacytoma, true extramedullary disease, is a different disease due to hematogenous spread, which is involving soft tissue, usually associated with an immature plasmablastic phenotype, often associated with high-risk cytogenetics, which is giving usually therapy-resistant and poor prognosis. The frequency of diagnosis is very low, so this is one of the issues to make specific trials for those patients because they are very rare. But during the relapse phases, the percentage can increase. On the contrary, bone-related or paraskeletal plasmacytomas are for sure a difficult clinical situation because the patient may suffer from this, may have pain, may have neurological complications. The frequency is high, up to 34%, but the prognosis is different. And you can see here from the PFS and OS curves of this quite large casuistic of that patient with bone-related plasmacytoma, the dark green curve is superimposable in terms of PFS and OS of the entire population, while the patients carrying soft tissue plasmacytoma, which is our unmet need here, are experiencing a worse PFS and OS. So it is important to identify those patients. So you may ask me, but how can I suspect bone soft tissue plasmacytoma if I'm not seeing them? Of course, if I have skin plasmacytoma, these are visible. Usually extramedullary disease is associated with high LDH and with a precedent history of plasmacytomas. So patients that, to my opinion, should be offered systematically an FDG PET-CT are those, of course, with clinical symptoms, those considered at high risk, for example, with high LDH or with a previous history of plasmacytomas. So usually in those patients, we are recommending FDG PET-CT, but of course, if the plasmacytoma or the symptoms are involving the CNS, we should prefer the magnetic resonance imaging, which is the gold standard for the evaluation, of course, of the spinal cord compression and the neurological complication. So what about this second imaging technique? This second imaging technique, MRI, is the most sensitive one. Why? Because, as I said before, it's looking a different thing. It's not looking to the bone damage, it's not looking to the beta-amyloid, but it's looking to the bone marrow infiltration. So by definition, multiple myeloma, even a smoldering multiple myeloma, is inducing bone marrow infiltration. So MRI shows the infiltration before the bone has been destroyed. So the sensitivity at diagnosis is up to 90%. And the discovery of focal lesion has a prognostic relevance as well in terms of progression-free and overall survival. In the last 5-10 years, the magnetic resonance imaging has been implemented by the use of the so-called diffusion-weighted imaging. This is an additional analysis of the tissue that is relying on the quantitative analysis of the free movement of water molecules. So the practicality of this technique is that it can attribute a quantification, the so-called ADC, apparent diffusion coefficient, to what you are seeing. So usually the bone marrow of adult is a fatty bone marrow, so the movement of water molecules is very low. So usually the ADC in adult bone marrow is low. When I have cells, so I have plasma cell infiltration of the bone marrow, so both focal lesions, but also diffuse infiltration, the ADC is going up, is increased. So the DVI technique, first of all, helped a lot to identify diffuse involvement of the bone marrow. This was something more difficult to detect with the normal MRI. So in a prospective comparison that the UK group very recently presented of DVI MRI and FDG PET-CT, DVI MRI was the winner. So the sensitivity of MRI was superior to PET-CT. And I may say that this was expected because, as I said, they are looking to different things. But also, very interestingly, they demonstrate a higher correlation of MRI with the serum paraprotein and the bone marrow infiltration by plasma cells. So potentially developing MRI as imaging markers for disease biology. I said that we also should use imaging to evaluate response to therapy. And you may say, but why? We already have our response criteria. We already have minimal residual disease evaluation in the bone marrow. However, multiple myeloma as a patch infiltration, we might have the case of extramedullary disease that by definition is outside the bone marrow, but also it is already demonstrated that the heterogeneity, the clonal heterogeneity of multiple myeloma is not only temporal, so it's not only developing over time with the subsequent relapse of the disease, but may be also contemporary at the time of diagnosis. So this spatial heterogeneity plus extramedullary disease plus patch infiltration pushed the International Myeloma Working Group to suggest to evaluate response to therapy by imaging techniques in addition to bone marrow techniques and, of course, paraprotein response. So what to use? The technique that has been traditionally used is FDG PET-CT. You can see here, these are 3 independent prospective trials evaluating the role of PET-CT after therapy, either before transplant or after transplant. And they are all consistent in showing that patients obtaining a complete suppression of disease metabolism by FDG PET-CT display a significant superior progression-free and overall survival. Once again, you may say, okay, but what about the MRD in the bone marrow of those patients? Are those patients also MRD positive in the bone marrow? Most of the cases, yes. But in 12 to 15% of the cases, there might be a discrepancy between the bone marrow and the imaging. Of course, this is applying to 10 to the minus 5, 10 to the minus 4 mainly, or 10 to the minus 5 sensitivity. So if we are going up with the sensitivity in the bone marrow, to the moment, we don't know what will happen by imaging. So this is under evaluation in current prospective clinical trials. But also during the relapse phases or in patients, as I said, carrying extra or paramedullary disease, the percentage of discrepancy between the bone marrow complete MRD negativity and imaging negativity is going up to 50%. So in those settings of patients, the recommendation to perform imaging is even higher and most important. Same results were reproduced by the Mayo Clinic group in the real-life setting. So not only within clinical trials, this is more easy because it's more standardized, but also outside clinical trials, you see that patients in complete remission, with a positive FDG PET-CT are experiencing a significantly worse, the blue curve, progression-free and overall survival. We can rely on standardized criteria to interpret the PET, so the job done by our group plus the French group and other groups was to try to suggest a threshold of positivity significant for progression-free and overall survival. This is not absolute, of course, but using the liver as the threshold of comparison for positivity or negativity is splitting the significance of the patient into groups. So we can apply this also in other trials. And for example, this was reproduced in the phase 2 randomized Forte trial in Italy, but it was also used by the UK group. These are a small series of patients relapsed refractory treated with KRD, where once again, the Deauville score and the definition of complete metabolic response was successfully applied. So independent series of patients were able to use these standardized criteria, which are not perfect, but at least are a way to make the results comparable. So currently, the main guidelines, International Myeloma Working Group, ESMO guidelines, are recommending the use of PET-CT by FDG to evaluate response to therapy. However, as I said, there is a small percentage of patients that is falsely negative, so not truly negative because the disease has a low metabolism. But for example, and this is only an example, maybe that's not the unique mechanism, they are negative because they are not trapping the FTG into the cells because they are lacking the enzyme. So of course, in those falsely negative patients, it's not worthy to evaluate response to therapy by the same technique. So what can we do in the falsely negative setting of patient? We can change of tracer. And several, mainly retrospective, but a little bit also prospective series of patients demonstrated that by the use of choline, methionine, or pentixafor, the sensitivity is higher. Very recently, there was also the demonstration of the use of specific tracer. For example, this very nice first-in-human experience with zirconium-89 linked to daratumumab, so very specific to plasma cell. Or the Nordics experience with flucyclovine, for example, demonstrated to be feasible. However, to my opinion, this is my personal opinion, there are not guidelines, I'm not seeing that much future in this tracer Because they are not standardized, they are very expensive, they need on-site production, but the main point is the fourth one, their demonstrated prognostic role is not in place. So we don't know what is the added value of the higher sensitivity of these techniques. At the same time, the availability of diffusion-weighted MRI is helping us in this setting, because standard MRI is not a good tool to evaluate response to therapy, because focal lesions are modifying by T1 and T2 capture of images very late on. So thanks to the use of diffusion-weighted imaging and the use of ADC, we are able to evaluate early changes post-therapy and late changes post-therapy. So the focal lesions are initially going up with the ADC because of the necrosis, and then they are going back to a low levels like in healthy people. So we can use diffusion-weighted MRI to evaluate minimal residual disease by imaging. And this has been standardized by the use of the so-called MyRADS criteria and has been applied in clinical practice. And this is a small experience on 64 retrospective patients studied by diffusion-weighted MRI. And you can see here that complete achievement of remission by the MyRADS criteria by MRI significantly improved progression-free overall survival and was complementary to the MRD evaluation at the bone marrow level. So this is the first retrospective demonstration. The UK trial currently ongoing, I think, and I hope will lead to the same results. So before concluding, I'm just sharing with you what is the work in progress. So this prospective comparison between PET and MRI are ongoing in different independent series of patients, as well as the confirmation of the definition of complete metabolic response. An important issue is the third one. So the redefinition of response, imaging response in patients receiving T-cell redirecting therapies and plasmacytoma, because we are not sure that those patients are exactly the same as the general population. And of course, the matching of imaging MRD with the new techniques, that is to say, liquid biopsy and mass spectrometry. So within the International Myeloma Society, International Myeloma Working Group, the last meeting, we were able to build this platform for collaborative international imaging studies. The main site is in New York by Jensis Illegas, and well, Spain, France, Italy, we are cooperating on this project to try to have a review of patients receiving T-cell redirecting therapies, also in particular to look on patients carrying plasmacytomas to try to achieve a new definition of response, merging the morphologic part and the functional part. And of course, last but not least, the use of automatic imaging analysis and artificial intelligence. So I want to conclude saying that, to my opinion, imaging shift from something running after the disease, so just making pictures of what has already happened, to something driving the disease, prognosticating the risk and driving the disease. Imaging is complementary to the bone marrow to assess the response of the therapy. We have two excellent tools, FDG PET-CT and DVY MRI. They can be alternative or they can be complementary. Some things are still under evaluation. To my opinion, the added role of new PET tracer has to be validated yet. And of course, nowadays we know that imaging is formally inside the prospective clinical trials, and I think this is a very good advantage to give an answer to still not responded questions. And with this, I conclude, and I thank you for your attention.
Thank you very much, Elena, for the excellent presentation. What are you using in a newly diagnosed myeloma patient? What would you? I think you said PET-CT maybe, but you also have the PET MRI. We also have here a good. It's not PET, but we have a very good MRI here. What are you recommending to do a diagnosis in a myeloma patient and to do the follow-up? This one.
Okay, well, my first recommendation is try to use the same technique. I think this is the most important one. So if you use MRI baseline, use MRI after treatment and vice versa. Otherwise, to mix different techniques, it may induce confusion. I think it's according to the facility and expertise, because the second recommendation is use the technique you are able to interpret in the correct way. Otherwise, for example, MRI sometimes is too sensitive, so you are finding things that you don't know which value to give to. And FDG PET-CT should be applied, of course, when there is a nuclear physician medicine with some expertise. We are using as a routinely FDG PET-CT. MRI in patients with not clear pictures, with doubts, with CNS involvement, and so on. I know that other centers are mainly prioritizing the MRI. That's okay anyway. PET MRI is under evaluation, is a very, very new technique. However, I think that it should still has still to be validated somehow, and it's quite time and money consuming. Yeah.
Okay, then thank you very much, Elena.
I have a question. Hi, Elena.
Hi.
Do you know if there are some difference between FDG and MET-PET in the detection of the extramedullary disease?
Not exactly on extramedullary. Usually methionine is supposed to be more sensitive, like choline, so probably also in extramedullary. However, I think that on extramedullary disease, FDG is performing very well. The problem sometimes are normal focal lesion. When with the metabolism is very low, the FDG can be falsely negative. Usually in extramedullary, FDG is sufficiently performing, let's say. So
perfect. Thank you very much, Elena. Thanks for joining us, and that was great. So now we move to the next presentation, which is Marc Raab from the University of Heidelberg in Germany. We are now fighting Germany. We fought Marc 2 days ago, and it was fine in the World Cup. So now he will be speaking about the signaling pathways in multiple myeloma. So Marc, let's see.
Well,
you can.
Thank you for the very nice introduction and reminding us that we just have 1 point in our World Cup team so far compared to Spain. At least I think we are 4 points now. Okay, so thank you for inviting me and getting me back to a project that we started quite a few years ago and still working on it actually. Is exploring signaling pathways in multiple myeloma, and as you see, I try to create my standard first page and with all your suggestions. And the second part is, I think what Google Translator said that this is probably conflict of interest. There wasn't so difficult to figure that out in Spanish. And yeah, so why are you looking at pathways, signaling pathways, oncogenic pathways in myeloma? You know, and you have probably heard yesterday from what I saw from a program, again, quite a bit about myeloma genomics and genetics. And you know, it's a quite diverse landscape, even on the genetic level in terms of translocations, copy number variations, and so on, but even more so on the mutational landscape with very few really recurrent mutations and maybe some mutational clusters and around signaling pathways or functional elements in cell biology. But there's very limited data on how does that translate actually on the disease pathophysiology and actual signaling, downstream signaling effects, what at the end drives actually the disease, the cell growth of myeloma. So we thought, as I said a few years ago, that we might want to look in actually in situ, so to say, or ex vivo. We might want to look into actual oncogenic pathway activation stages in myeloma cells from different patients. And as you can see here, just as a reminder, we have many of the known oncogenic pathways here included in this cartoon. And we focused on 5 of them, of course, well-described pathways where also really activation markers in myeloma have been evaluated in vitro for many years for in vitro experiments, but also, of course, known to be functional in many other disease entities, specifically, of course, also solid tumors. So we concentrated on the MAP kinase signaling pathway, so RAS, RAF, MEK-ERK signaling. We looked at the PI3-AKT pathway, JAK-STAT pathway, the canonical NF-κB pathway, and actually on MYC expression, which is not in a more narrow sense a pathway, but kind of a signal integrator, but in an oncogene by itself. Because all of them had at least known and previously described markers of activation, we evaluated them. I will not go through all the details how we came up with the actual phosphoimmunohistochemistry antibody setup, but that was quite some extensive evaluation and validation. And then we, as I said, started the program looking at different disease stages, as you can see here. I hope you can see my arrows in the upper left part: smoldering, newly diagnosed, and refractory myeloma. So there's the three main stages of myeloma, of course, disease stages. For clinical relevance, looking for associations with known risk factors, known clinical parameters, and some ideas on molecular signaling when we actually look into certain mutational data that we had available for this cohort, and that's exactly what we're still working on. And hopefully we'll be able to show quite an extensive new data set then next year. And of course, the evaluation of signaling in different, not only disease stages, but in also disease situations, like sequential biopsies, and of course, also extramedullary disease and so on. So we started off with looking at the MAP kinase pathway. That's how we all wanted to look at it at first, because as you know, RAS, RAF mutations are the most prevalent mutation group, so to say, in myeloma. And then we disseminated, or we widened the picture to all these pathways I just laid out to you in the previous slides. So what were the patients, the samples of the patients, where were the samples coming from? As I said, smoldering, we had a small group of 33 patients with smoldering myeloma. They all confirmed smoldering. So we followed them for 2 years, making sure that they were not just developing myeloma, so really being smoldering for at least 2 years without having translated into slim crab positive myeloma. A set of newly diagnosed myeloma patients with 194, 150 around refractory myeloma patients with many prior lines of therapies. And this were basically the training set to evaluate the landscape of pathway activation. And then we had 2 cohorts from clinical trials, one with 84 newly diagnosed patients out of a G trial, and a larger cohort from total therapy trials from Little Rock with 428 patients, all part of the total therapy 3 or 4 clinical trials. This is just depicting a summary how phosphoimmunohistochemistry looks like, and you know this is of course we need either a specialist pathologist or a automated system to read that out, or ideally both. We now have both. We have an automated readout system that depicts the spread, so to say, the percentage of myeloma cells or plasma cells that are actually positive or non-positive, or graded in terms of how how far the activation level went into the individual cell, and of course then the overall picture of the individual patient biopsy of these plasma cells, and always correlating this to positive controls. For example, for phospho-STAT3, you have endothelial cells that are known to be always very strongly positive, and so on. And this then was integrated in a nonlinear principal component analysis to have, at the end of the day, one value for each pathway in each patient sample integrated for statistical analysis. And just to set the stage a little bit around all that, why we started with the MAP kinase pathway, we know that activating mutations in the BRAF gene can, what happened now? Okay, this is an old animation. Okay, can be successfully treated with BRAF inhibitors and MEK inhibitors. And there was also a complicated paper because it's quite a heterogeneous patient group by Chris Hoyk a few years ago, quite some years ago, who showed that RAS mutations, at least to some extent, might correlate with a response rate, a moderate response rate when using MEK inhibitors. So we started, as I said, with the RAS-RAF mutations, and here on the upper left, you see that the patients are lined up here according to their KRAS, NRAS, or BRAF mutation. You see here, so this is the patient group that has a KRAS mutation, any KRAS mutation. This is the NRAS mutation, that's the one with the BRAF mutation, and very few patients that have concurrent RAS NRAF mutations. And as you can see, by far the most patients with a BRAF mutation that we are not only activating with all kinds of BRAF mutations, but many of them here depicted in the red had an activation of the phosphor-ERK, so the MAP kinase pathway downstream marker here. Whereas for KRAS, it was only about half of the patients that actually showed a downstream activation on a phosphohistochemistry level, whereas the NRAS mutant patients, only a minor fraction had actually a downstream pathway activation of the MAP kinase pathway. So statistically, it was like that a KRAS mutation in a respective patient still was statistically associated with a more high likelihood of an ERK activation downstream. However, as I said, it's only about half of them, whereas no correlation was seen between the NRAS mutation and the activation of the pathway. And actually, when we are looking, I'm not showing this in detail now, but the bottom line is when we're looking at the individual mutations, so the individual amino acid changes, there were only 2 mutations, one in BRAF, the known V600E, of course, and one in KRAS, the G12D, that were consistently associated with an ERK activation. So that's probably an important message when you think about how to treat a RAS, whatever RAS mutation the patient has, according to the RAS mutation. And of course, when we looked at different disease stages, NRAS turned out to be the most different, or the most strikingly different one in terms of prevalence between the newly diagnosed and the refractory patient setting here. Whereas the other mutations did not really change a lot, at least the KRAS did not really change. The BRAF mutation in general were a little bit higher in prevalence at the refractory stage compared to the newly diagnosed stage. But it seems to be that NRAS mostly drove the higher prevalence of RAS-RAF mutations in general between newly diagnosed and refractory patients. Then, as I said, we added the other pathways to the whole picture. And let me walk you briefly through this very colorful picture here, graph here. You see here unsupervised clusterings between smoldering patients or newly diagnosed patients and of refractory patients, and the respective pathway activation. Red means high activation in the respective samples. Each column here is basically one patient. So and the dark kind of purple is no activation whatsoever, and the grading between all these colors are then from 0, so to say, no activation, to 1 full activation or whatever. Yeah. And what you can see here, if we start with the smoldering myeloma, you see that the smoldering myeloma have overall a high prevalence or a high activation of the NF-kappa B pathway, and a small group of the smolderings are characterized by an ERK activation. And what you can also see here already, that there seems to be a kind of a dichotomy. So there's a group of patients strongly activating NF-kappa B pathways at the majority. And then you have a small group that has ERK, but no or hardly any NF-kappa B, or very low NF-kappa B activation. And overall, if you combine then on the newly diagnosed part, if you combine ERK and AKT, that seems to be going kind of along together, you see that you have an ERK AKT activated patient population that has low levels of NF-kappa B, and you have Another patient population with NF-κB on the right side here, activation with very, very low ERK activation at all. And then you have MYC and STAT3 kicking in slowly in the newly diagnosed setting that was barely absent in the smoldering. And if you look now at the refractory patient population, you already see that's a very colorful picture overall. You see many pathways activated at the same time in parallel. And you see that MYC and STAT3 become much more frequently activated compared to the early stages of myeloma. And still here you see, to some extent at least, the kind of the dichotomy between NF-κB activated and the much bigger, larger cohort of AKT and or ERK activated patients. And so if you then look into a more statistical analysis, you also can confirm that there's a clear negative correlation between NF-κB and ERK in all, this represented here by this blue bar in the spider plot kind of things here. So across all disease stages, negative correlation between ERK activation and NF-κB activation, whereas there are increasingly positive correlations between MYC and STAT3, so the ones that kick in later in the disease course, and the correlation and co-activation of ERK and AKT. So there seems to be two different biological mechanisms behind these activation parts across the disease stages. And to confirm that this is in principle at least true, of course this is not black and white, but in principle it's true, we compared consecutive samples from individual patients. So all patients where we had two consecutive, so baseline and relapse, for example, samples at two different stages of the disease of the patient. And here, it's a bit different. Red means that there was an increase between the two samples over time of the disease activation, of the pathway activation. Blue means there was a decrease between, so it's a dynamic depiction here. Red is an increase and blue is a decrease. And what we in summary see already here again, that we see kind of two groups. One also over time, that where NF-κB is increasing in activation of these patients over time. And at the same time, ERK and AKT are decreasing in activation. So again, a different scenario in terms of how those pathways react over time, and vice versa. So to some extent, NF-κB, if you lose NF-κB activation over your disease course, you gain ERK and AKT activation. And in consistency, MYC and STAT get activated in later stages of the disease. Last but not least, we looked into the mutations again. I already showed you the RAS and RAF mutations in correlation with the ERK pathway. That held true for the newly diagnosed patients still, but no clear association between any RAS mutation patterns and the other pathways were seen in this, at least in this readout, with about 66 patients where we had this information. But as I said, we're increasing this patient number quite a bit. In refractory, it was interesting because much more patients had an NRAS, any NRAS mutation, but had an NRAS mutation. And you can see that this seemed to correlate to some extent with the MYC activation. So MYC or MYC expression, so high MYC expression and NRAS mutation in the refractory patients showed quite some association, whatever that means at that stage, at least, I have to say, biologically. And finally, we, of course, correlated this also with clinical outcomes, checking whether, especially STAT3 and MYC, where we see that these are, secondary events that, drive, obviously, the disease progression, absent and smoldering, kicking in newly diagnosed and really taking over the game in refractory patients. And so we looked for the prognostic value of STAT3 activation or MYC expression at newly diagnosed patients. And as you can see in the ChIM-MG data set here from ChIM-MG HE4 trial, you see that STAT3 activation had a negative prognostic impact for PFS as well as for overall survival, whereas MYC did not have much impact on the, a little bit, but not a statistically significant impact on the PFS, but showed a shorter overall survival to some extent as well. And to validate this in an independent data set, I mentioned previously, we used a large cohort of 430 patients from the total therapy trials in Little Rock, and what we saw in general, not showing as a figure here for now, but in general, we found that high MYC activation was at baseline, was even in the total therapy cohorts associated with shorter PFS and shorter overall survival. The same was shown for activated STAT3 for shorter PFS and overall survival in this heavily treated, so intensively treated, let's put it this way, total therapy cohort. And then we looked into the risk groups, and you know that the total therapy patients always were characterized in terms of risk grouping by the CHEP70 score. So the gene expression 70 score developed by John Shaughnessy and colleagues many years ago, which quite nicely discriminates high risk from low or ultra high risk from low risk from low risk myeloma, let's put it this way. And when we combined a STAT3 activation with the CHEP70 score, we found that, and this is the red curves here, and that is the PFS, and this is the overall survival, that activation of STAT3 in these patients that are, in addition, had a high-risk CHEP70 score, did really, really poorly, much worse than all the other patients shown and treated within these trials. And when we then analyzed the gene expression data that were, in general, of course, also available from these patients, we found now that some indication that obviously these myeloma cells of these patients seem to have an autocrine IL-6 loop that triggers intrinsic their proliferation and survival, and then of course activates STAT3 in their disease biology, and obviously then do really poorly even if you apply total therapy approaches. So in summary, what I try to show you is that we have an increasing complexity in pathway activation along the disease evolution. And it seems to be that it can be broadly classified in NF-κB-driven myelomas and ERK-AKT-driven myelomas, at least broadly. And we have with STAT3 and MYC markers and activation patterns that really seem to drive the disease in the more refractory setting, towards the more refractory setting, and to more the refractory, so the I would say that the treatment refractory, treatment resistance stage that also then kicks in when we analyze prognostic values, if those markers already are present in at baseline. And this tries to be a graphical depiction that Leo Russia at some point drafted here, which summarizes basically our findings. And with this, I thank you for all the attention, and of course for all the team effort that made this possible when we did this now over several years. Thank you very much.
Thank you very much, Marc, for the great overview on these pathways, in particular the MEK, the STAT, the NF-κB. Is there any question? I can start. I have several of them. One is, well, I have one is that I have always been struck by the results of the trial with the BRAF inhibitor plus the ERK inhibitor. So combining these two pathways, that you achieve 80% responses or very high number of responses, and they were durable. You don't know if they were still durable. So do you think that's something we can pursue to look at for in myeloma for such a targeted strategy? And well, that's my first question.
Yeah, so I have to spend most of the night to do the revision. So because we have to resubmit the white paper of this trial we are alluding to by tomorrow. So yeah, so actually small patient numbers, right? So yeah, we're only talking about this one most famous, of course, BRAF mutation, the V600E, which consistently activates the downstream pathway and seems to be really an oncogenic driver in those few patients in myeloma who carry this mutation, at least if they do not carry a concomitant RAS mutation, which without MEK and ERK inhibition, they rarely do. Anyway, so, and yes, combining BRAF and MEK inhibition here leads, at least in our hands, but also in some case series, to quite nice response rates, even in refractory patients. In our hands, it was 10 out of 12 patients, so but technically it's 80%. I agree. However, some of them are indeed long-lived, these progression-free, and the responses are long-lived in some of those patients. Actually, about a third of the patients were on treatment for more than 1 year. We still have one now out 3 years now under therapy without progressing. So some of them do experience a very long duration of response. However, some others do not, who have a quite short-lived response. Some will, of course, then less than 1 year. And those patients, at least it appears, seem to develop, for example, RAS mutations quite quickly. Whether they were present from previous lines already and not detectable in the initial sample, or is just because of some genomic instability being selected, that is of course largely unknown. And I mean, it comes down to all the basic question, are all these subclones present from the beginning and we don't see them, or are they developing? Well, probably both, and we know there are different scenarios. So I would, to come back to your clinical question, if you do a routine bone marrow analysis of myeloma cells, and you do anyway like a panel sequencing or an immunohistochemistry analysis, I would include a BRAF V600E either as a panel sequencing approach or as a mutation-specific immunohistochemistry approach. Just to know that and use this information for individualized treatment for this very single patient then. And we did that now for bridging towards CAR T-cell therapy, for example, and also then because they respond quickly and most of them respond. And especially if you do like a bridging to another therapy, it is not essential so much whether you have, like a 2 years PFS or a half a year PFS, because you want to get the patient in remission and then transition to like an immunotherapy. That's what we right now actually use it most, of course, in addition to the really refractory patients where we are in need of any therapy.
Perfect. Okay. Thank you. Thank you very much, Marc, for the great and congratulations for all your work. Next, we move to another one of the other important pathways in cancer, and also we know it's also important in myeloma, which are the anti-apoptotic pathways. And for that, we have Larry Boyce from Atlanta, that he's also an expert and has been working a lot in this BCL2 and all these anti-apoptotic pathways, particularly in myeloma. So thank you very much, Larry, and that's for you.
Thank you, Enrique. A pleasure to be here, and thanks again for the invitation to be amongst friends too. And so I second that motion to do this in Spain. All right. So as Enrique mentioned, I'm going to be talking about the anti-apoptotic pathways in myeloma. Here are my disclosures, and I try to get the most important slide out first, which is the recognition of the people who do the work, and I'll mention them during the talk as much as possible. But current and former members of the lab, our wonderful myeloma team at Emory and collaborators. And as slides jumping along here, back up there. And as Enrique mentioned, I'm going to be talking mostly about and thinking about anti-apoptotic pathways, not the signaling pathways that Marc talked about, which can lead to pro-survival signaling, but to where this all is controlled, which is the BCL2 proteins. And just as a quick reminder, this is a large family of proteins that have different activities. There are anti-apoptotic proteins, which there are 5 of. There are and they're shown in green in these slides. There are pro-apoptotic proteins that are the effectors of the process we're going to talk about. And there are there's 3 of these primarily, and really 2 of them are really relevant in myeloma backs and back. And then there's a bunch of these proteins called BH3 only proteins. They're also pro-apoptotic, and they seem to come into 2 flavors, and they're going to be shown in orange as the activators, which are BIM and BID and PUMA, and in yellow are all the rest of them that are known as the sensitizers. And the way this works is that in a cell you have the effector proteins there, so they're the ones that are going to cause the changes in the mitochondria. but they have to be activated. And the way that happens is that you have some kind of stress, and that results in BAX moving to the outer mitochondrial membrane. That stress can induce proteins like these BH3 sensitizer proteins, and their function is to inhibit the antiapoptotics and release these BH3 activators. The stress can even induce the expression of these BH3 activator proteins as well. And in doing so, you have these free BH3 activators, and by their name, one can imagine what they do is they're the activators of BAX and BAC, and that causes them to form pores in the outer mitochondrial membrane, release cytochrome C from the intermembrane space, and induce caspase activation and ultimately the demise of the cell. And one of the things that we know about cancer is that one of the hallmarks has been evading apoptosis. But this raises a bit of a paradox, because if you have to evade apoptosis to become cancer, then shouldn't you be more resistant to apoptotic signals? And if that was true, then cancer cells would be harder to kill than normal cells, and that most of our therapies would be better at killing patients than we are killing tumors. But clearly that's not the case. And so there must be a reason why the cancer cells are actually more sensitive to the types of therapies. And the molecular basis of this is they actually become more dependent on these BCL2 proteins. And that's shown here in a process or a term that's called mitochondrial priming that was coined by Tony Latai. And this is just showing the binding of in this case, the BH3 sensitive activator BIM to these different anti-apoptotic proteins. And it's a one-to-one binding. So the size here really represents the pool of BIM. And there's just more BIM bound to more MCL1 in this case, which is really what we find in myeloma, that we see much more dependence or priming on MCL1 than other cells. And because you have this level of priming, when you add therapy, the sensitizers can cause the release of BIM and activation of BAX and BAC and cytochrome C release. Well, this is not what's seen in normal cells, where there is very little priming that's going on, so very little BIM bound, and therefore the therapy doesn't work. And so it's actually the evading apoptosis that ultimately makes the cells more sensitive to this possibility. And an example of this in myeloma was published by the Latai lab some years ago, where they showed in a series of patients, of myeloma patients, where they looked at mitochondrial priming, they found an incredible correlation between priming and response to therapy. And this was regardless of what the therapy was. And so that tells you that all of our therapies were working through this mitochondrial pathway, at least the ones we were using then. And that's still true today, that almost all the therapies we're talking about, whether you're inhibiting the signaling pathways that Marc talked about, or even the immune therapies, particularly the cellular therapies that I think we're going to hear about from Niels and from Michael in a little bit, can work through this pathway. The issue is that, as Marc mentioned, there's a lot of heterogeneity in these in the signaling pathways that could be activated, and this opens the possibility of resistance mechanisms. And so one way to evade all of these types of resistance mechanisms associated with indirectly activating the apoptotic pathway or engaging this pathway is to directly inhibit it. And that's through the use of drugs like a MCL1 inhibitor, a BCL2 inhibitor that are as a family called BH3 mimetics. And so that's what I'm really going to focus the rest of the talk on. And we now have a lot of these drugs over the last 10 years that have been developed that are either specific inhibitors of MCL1, BCLX, or BCL2. The BCLX inhibitors haven't really moved very much in the clinic to this point. It turns out platelets are very dependent on BCLX, and so you get severe thrombocytopenia, although it can be manageable, and that was shown in some early studies with the drug I don't actually have on here, navitoclax. There's been a lot of work that's showing that MCL1 would be a great target in myeloma, and actually preclinical work, including that from Enrique, demonstrating this. But these have not actually advanced that far in the clinic either, due to some toxicity that actually in some ways was predicted by early mouse models of loss of MCL1. And there's still some hope there, but I think that we may need different molecules or different inhibitors to move forward with that. And the one drug that so far has really moved in the clinic has been venetoclax, so the BCL2 inhibitor. And in myeloma, it's been a very unique case where in the first phase 1 study, what we saw was that while the overall response rate in the study led by Shaji Kumar was only 21%, the overall response rate in the 11-14 patients was 40%, and the rest of the patients was only 6%. And so this ends up being really the first defined precision medicine in myeloma, although the trial wasn't defined that way. However, there was preclinical data that might have predicted this, and I think a lot of the physicians ended up putting patients on that had 11-14, which threw off the balance of the trial. Based on preclinical data from my laboratory, from Shannon Matulis, showing how venetoclax and dexamethasone synergized, we actually convinced AbbVie to open a expansion cohort of this phase 1 in 11-14 patients with venetoclax and dexamethasone, and we saw a 60% overall response rate in that phase 1. It was moved to a phase 2 where the response rate was a little bit lower, but these were a little more heavily pretreated group of patients. Unfortunately, this phase 2 had to be shut off because of what was happening in another trial at the same time, and that trial was Bellini, which was a phase 3 study of venetoclax or placebo with bortezomib and dexamethasone in patients with relapsed refractory multiple myeloma. And this was all comers, not just 11-14. And we saw this unusual situation where for progression-free survival, the addition of venetoclax was significantly, had a significant outcome effect. However, you saw the opposite effect in the overall survival, and that there was actually more deaths. And these were all really early deaths in this study, and this caused us to stop our Vendex study, and that became actually now part of a study with Vendex versus Pomdex in 11-14. These early deaths have been attributed primarily to infection, although I would caution to say that we did not see infections in the 11-14 or the high BCL2 patients in this. And so it seems that it was only in patients that were less likely to respond in the therapy. So I think there's still a lot to be learned about what happened in this study moving forward. In our lab, we were trying to understand, going back to the phase 1, was why is it only 40% of the 11-14s, and who are the other 6%, the other patients that responded, and could we learn more about it in who are the subset of patients who are responding within the 11-14? So this is a study we published last year, led by Vikas Gupta, looking at cell lines and patient samples that were treated with venetoclax, and the green are the sensitive and the orange are the resistant lines. And what he showed was that in both the patient sample, there was a gene set from the cell lines that actually was enriched in the patient samples as well. And you can see that when he looks at all the genes that were significant, shown in black, and doubly significant in both lines and patient samples in red, there were a lot of overlap in the genes that were upregulated in the venetoclax sensitive. However, none of those genes say the word BCL or BCL2 in them, and that's because we didn't really see differences at the RNA level in BCL expression in BCL2, BCLX, MCL1, and only in these really one patient was there a difference in these ratios. And so what was really different in these? And what we found was, in looking at gene set enrichment analysis, that it was that these myeloma cells that were sensitive, both in the cell lines and patient samples, expressed a lot of B cell markers, and they were associated with a group of 11-14 group defined by Frank Zahn and John Shaughnessy some time ago, called the CD2 group, which were primarily 11-14 cyclin D1 upregulation that also had B cell markers like CD20 and CD79A. And so it looks like that's the group that was enriched. And so what Vikas did is he actually looked at B cell and plasma cell surface markers, doing flow cytometry first in cell lines, and showed that it accurately predicted sensitivity. He came up with an algorithm using 5 of the most differentially expressed ones in this group, and that algorithm was then applied back to the cell lines, and it predicted sensitivity in all of the cell lines except for one, as well as in a group of patient samples where there was an 82% sensitivity and an 80% specificity. And within this group, there was also 8 patients that were treated with venetoclax, and it predicted 7 out of 8 correctly. The other thing that was predicted in that 7 out of 8 correctly was actually the ex vivo test itself. And that was something that we had been working on some time, and it came out by testing a lot of samples ex vivo. What we found in a 24-hour apoptosis assay mimicked what was found in the original phase 1 study. And if we treated cells for 24 hours and determined an IC50 and just said, initially, as I'll show you, it looks arbitrary, but there's a reason we set 100 millimolar cutoff in this study was that about half of the 11-14s were below that number, and about 10% of the non-11-14s were very similar to the sample studies. When we look at those patients, we can see here are all those samples laid out, and they fell into really three groups: a sensitive, an intermediate, and a resistant group. The 11-14s are marked by asterisks, and you can see they actually are found across all of them, but again, consistent with about half of the 11-14s being sensitive and half being resistant. What was really interesting was when we looked at patients who had received venetoclax, and these are all pre-venetoclax samples, was that all of the responders fell into that sensitive group. And so the being sensitive predicted the response, while of the non-responders, only one was sensitive and the others fell into the intermediate or resistant group. Vikas has now extended this study a bit, where he now has 28 valuable patient samples where he's looked at this. And again, if it's sensitive in an assay, those patients respond, with only the one patient so far really that didn't, that had stable disease. We now see some responders in the resistant group, although it's significantly lower, and is only a third of, only 3 out of the 9 had a VGPR or better. And so when we looked at the 4 patients who responded there, what we see, well, before we even get to that, we can see that this now test predicts progression-free survival. You have a significant difference there, and it actually has a very strong receiver-operator characteristic curve, area under the curve, consistent with a biomarker. And so we wanted to know who those patients were that were resistant in our test, but responded. And it turned out all of them had received venetoclax and dexamethasone. And in 3 of them, we actually had done ex vivo testing that way as well. And you can see in 2 of them, the dexamethasone, consistent with our earlier preclinical studies, had sensitized the sample, and explains why we see this discrepancy, because this test is venetoclax alone. The 3rd one, we saw a change, but it didn't drop it as low. And the 4th one, we didn't actually do the analysis with dexamethasone, unfortunately. We've actually extended this and found that we can also see acquired resistance in this way, working with Paula Neri and Nizar Balis and in one of their patients, and we're able to find a BCL2 mutation that actually explained the resistance in that case. And so with that, I'd like to just conclude that, venetoclax sensitivity is associated with B-cell markers in myeloma, and this provides a unique opportunity to use phenotypic profiling as a prognostic marker, that the heterogeneity of the expression of these B-cell markers in myeloma suggests that they're not progenitor-like cells, that these are, I didn't really go over that, but these are not a normal immature plasma cell state, that there's something about an altered differentiation related to myelomogenesis. And for testing purposes, it will probably require a panel of antibodies. Again, this is published, but I didn't show it here, that if we only use CD20 alone, it wasn't predictive. And we had that data. And that the ex vivo testing actually works very well. It works as well as if you do BCL2 IHC. However, it's much quicker and less subjective. However, that test is somewhat limited to academic centers. So our goal right now is really to figure out how to generate more of a point of care testing using that kind of functional testing. So with that, I'll thank you and be happy to take any questions.
Thank you very much. Also, Larry, for the excellent overview on these pathways, BCL2, MCL1, so antiapoptotic. Any question? I have some of them, several.
I have one, Larry. Good afternoon. Do you have any explanation for the increase of MCL1 after the treatment with the BCL2 inhibitor? Maybe it's because it's a mechanism of drug resistance, or if you see if any combination with the BCL2 inhibitor can restore the expression of MCL1.
So you do see that on occasion. We don't see that in every sample that we've looked at, but it can happen. And actually, Paula and Nizar had a really interesting case where they had done single cell copy number analysis, and what they found was that there was a focal amplification of MCL1. Now, so just to back up, MCL1 is on chromosome 1q. And so it's in a region that's commonly amplified in myeloma, but this wasn't a 1Q gain. This was a very focal amplification right around MCL1. So the rest of 1Q was not amplified. So that's very consistent with that you've upregulated that. But in many other patients, we just don't really see the MCL1. You see the BCL2 mutations, which is the most common change also associated in CLL, in venetoclax resistance. In the original studies, half of the relapsed patients had a BCL2 mutation, and they were very much like the one that we had analyzed with Paula and Nizar, which was that it didn't actually affect BCL2's ability to bind to BIM, but it affected the drug's ability to displace BIM. And so the cell was still BCL2 dependent. We just couldn't target it any longer. But I think in the cases probably where there's a 1Q gain already, one can envision that it's much easier to also upregulate the MCL1.
So, Larry, do you still see a path forward for the MCL1 inhibitors? I mean, we had quite some patients in these trials, and actually a few of them, but some of them are really nicely responded. But I think there's some cardiac toxicity issue. Any take on that from your side?
Yeah, I mean, so I think we've all have shared your experience, Mark. Thanks for the question. And that, had the most promise, I think, because of so much MCL1 dependence in myeloma. Normal plasma cells are actually MCL1 dependent also. So it's something that's maintained from the cell of origin. I think that the cardiotoxicity is something that we had known was a possibility for about 10 years. So Joe Offerman had shown this using conditional knockout mice with MCL1, and that was the big developmental problem, or early problem was that. And so it wasn't that surprising to see that. As potent as these drugs seem to be, I think that maybe the problem is they're still not potent enough that we can get a therapeutic window, so that I think we have to use probably too much of them at this point. And so I think, I don't know if the drugs that we're currently using are going to be the answer. I think we may need some refinement on those moving forward, and maybe that's it. Combinations is always a possibility, but I think they've also, where in AML, where there was a little more success with the MCL1 inhibitor and they weren't seeing the cardiotoxicity because they could use lower doses, when they started combining it, they had to shut off with venetoclax. They had to stop some of those trials too because of the cardiotoxicity. So I worry a little bit about the combinations at first. I think we just need a better drug still.
Okay. Now we move to the last part. Well, the last part of the 3 last talks would be, we move to the immunotherapy, speaking about monoclonal antibodies, T-cell based therapies, and NK-based therapies. To speak about monoclonal antibodies, we have Yong from the University College of London in the UK. We have like 17 minutes for each of these 3 presentations before 6:30 to have the keynote lecture. So thank you very much, Kwee, for accepting the invitation, and the floor is yours.
Hello, Enrique. Thank you for the kind introduction, and thank you for inviting me to speak. So my remit is to talk about monoclonal antibodies in multiple myeloma. Here are my disclosures. I'm going to start with going through some of the targets in multiple myeloma. Here is illustrated a myeloma cell with some of those signaling pathways that you heard about earlier from Dr. Raab, and also BCL2 and the apoptotic pathway that Dr. Boise has so nicely illustrated. I'm going to talk about stuff on the surface of the cell now. And so the first target to talk about is CD38, which is targeted by daratumumab and isatuximab. Now, these are naked antibodies, as is elotuzumab, which targets SLAMF7. We also call this CS1. Other targets are, of course, BCMA, which is targeted by a antibody drug conjugate. So this is a different sort of antibody. And the one that is licensed is belantamab. And BCMA also, of course, is targeted by bispecific antibodies. And this includes the product, which is the drug teclistamab, and I think Dr. Niels van der Donk will talk about bispecific antibodies, because they're, again, a different group of antibodies that redirect T cells. Here are some other targets I want to talk about: GPRC5D, FCRH5, CD47, which is a don't eat me signal, and of course CD138, which is a marker for malignant plasma cells. I'm going to start with CD38 antibodies, and these are interesting antibodies because they have a direct effect to kill the myeloma cell, but also an immunomodulatory effect on the immune system. So on the left-hand side are direct effects on the receptor. I'll talk about this a bit later. Complement-mediated cytotoxicity mediated by the FC portion of the antibody, but also FC-dependent mechanisms of killing the myeloma cell are antibody-dependent cellular phagocytosis, and also cellular cytotoxicity by NK cells. So NK cell-mediated cytotoxicity mediated by FC receptors is probably one of the major activities of these antibodies. But also there are immunomodulatory effects because, of course, CD38 is also expressed on immune cells. So, sorry, let's go back. So the CD38 antibodies can downregulate and eliminate Tregs, but also stimulate T cells and cytotoxic T cells, downregulate the immunosuppressive cells, Bregs, and also myeloid-derived suppressor cells. So the next few slides will just take you through some of the clinical data that underlie the licensing of these antibodies in the clinic. The early reports that we had of the activity of CD38 antibodies derived from both daratumumab on the left and isatuximab on the right. And you will see here is in the waterfall plot the response rate in heavily pretreated patients of daratumumab. This goes back some years now. Similar response rates for isatuximab. Now, the main side effects are infusion reactions. They mainly occur with the first dose. They're rare after cycle 1. Other effects that come on after perhaps longer use are anemia, fatigue, sometimes neutropenia. But of course, we have moved on from single agent use because we've understood now how to combine CD38 antibodies in combination therapy. So with immunomodulatory drugs, lenalidomide and pomalidomide, with proteasome inhibitors, bortezomib and carfilzomib, and also in multi-drug induction regimens for newly diagnosed patients. So just quickly for looking at the combination therapy with anti-CD38 antibodies and treatment of relapsed refractory multiple myeloma. Now I show you here data from 2 studies. So some of the early studies in combination of CD38 antibody with standard of care relapse therapy. So daratumumab with Lendex in the Pollock study, daratumumab with bortezomib dex in the Castor study. Now what I've shown here for you is the response of patients broken down by MRD status. Now you heard Elena Zamagni talked to you earlier about bone marrow-based MRD and PET-CT also used to measure depth of response. This is bone marrow-based MRD, and the progression-free survival for patients receiving the Dara-RD here on the left is in blue, and the control RD is in red. And you will see that for patients receiving Dara-RD, for patients who are MRD negative, that there is an impressive improvement in progression-free survival, not only over MRD positive patients, but also the control patients who are MRD positive. The main thing to note about the combination with the antibody is that so many more patients achieve MRD negativity, and you will see here in the numbers down here, and the same is true also for the Castor study with Dara, Velcade, and dexamethasone. Now, isatuximab is a second-generation anti-CD38 antibody. It also has some of the activities, cytotoxic activities towards myeloma cells that we spoke about earlier, but also targeting the T-cell axis immunomodulation. But another important action of isatuximab is inhibiting a CD38 ectoenzyme activity. The ectoenzyme activity of CD38 increases adenosine in the bone marrow microenvironment, and this is immunosuppressive for many immune cells. So in general, not only do these antibodies kill myeloma cells, but they stimulate the immune system, and they overcome some of the suppressive mechanisms. So this here you see the results of two studies, phase 3 studies, combining a CD38 antibody, isatuximab on the left and daratumumab on the right, with carfilzomib and dexamethasone. Now, carfilzomib is a second-generation proteasome inhibitor, very effective in the relapse setting, but also in the frontline setting. And the combination of carfilzomib and dexamethasone is a licensed combination in the relapse setting. But you see in both graphs here that the addition of a CD38 antibody improves progression-free survival. And impressively, for these patients who have received 1, 2, 3 prior lines, the median PFS is not reached here in the IKEMA study and is well over 2 years here in the CANDLE study. What about CD38 antibodies in the treatment of newly diagnosed multiple myeloma? Well, here is the study design of 2 studies that have combined daratumumab with treatment regimens that are standard of care for patients who are newly diagnosed myeloma who are non-transplant eligible. So older or perhaps less fit patients, and daratumumab combined with VMP in the Alcyone study, or daratumumab combined with RD in the Maya study. Now on the next graph here, slide here, you will see the results of these studies, Alcyone with daratumumab, VMP. So this is a 4-drug regimen on the left, daratumumab RD, a 3-drug regimen on the right. And once again, like you saw in the curves in the relapse setting, the addition of a CD38 antibody improves progression-free survival with an early separation here of the progression-free survival curves, a bit later separation, but clearly the curves continue to separate, and there is an advantage of adding a CD38 antibody to standard of care regimens. And this is generally the picture you will see when a CD38 antibody is added to a standard of care regimen, whether it's 2-drug or 3 drugs. And this speaks to the different mechanism of action, of course, of CD38 antibodies. But these antibodies are not only effective when added to multi-drug regimens in relapse or newly diagnosed myeloma, they've also been trialed in the relapse setting. Now, this is the Cassiopeia study, which was carried out in newly diagnosed patients who are transplant eligible, where daratumumab was added to the standard of care regimen VTD compared to VTD alone. But I want to draw your attention to the second randomization, which was a randomization of patients after a transplant and after consolidation to receive either daratumumab monotherapy as a maintenance or observation in the control arm. And on here you see the results of the second randomization, which is testing the efficacy of daratumumab as a maintenance compared to observation alone. Once again, you can see an early separation of the PFS curves, where the median PFS in the daratumumab arm is not reached, versus nearly 4 years in the control observation arm. So these CD38 antibodies may also be effective as single agents in the maintenance setting when patients have achieved a deep response. And this is a phase 3 study. This is an interesting study because it's a combination of isatuximab, so the other CD38 antibody, with RVD, another standard of care induction regimen. And what is interesting and different about this study is that there's a longer number of greater number of induction cycles and the deep MRD negative response prior to HSCT. But also note here, the CD38 antibody is combined with lenalidomide. Now, lenalidomide is the standard of care licensed regimen for maintenance post stem cell transplantation. And this is not the only study, but it represents one of many studies which are adding a CD38 antibody to standard of care lenalidomide compared to lenalidomide alone as maintenance, and in this case for 3 years or until progression. Now, a different antibody, I spoke about this briefly earlier, is elotuzumab. Elotuzumab is a humanized IgG1 antibody directed against CS1. On that first slide I show you is called SLAMF7, same thing. And here you see that what this illustrates is that the main activity of elotuzumab is to engage NK cells and cause antibody-dependent cellular cytotoxicity. Because CS1 is also expressed on NK cells, elotuzumab probably also has activity of engaging and activating NK cells. The net result is to cause cytotoxicity of myeloma cells and to also reduce adhesion to bone marrow stromal cells, which might upregulate some of those anti-apoptotic molecules that you heard about, MCL1, BCL-XL, from Dr. Boise. The interesting thing about elotuzumab is that it has no single agent activity, at least not in the trials that have been run in the relapse setting. But there are phase 3 trials with Lendex and Pomdex. And here I will show you the ELOQUENT-3 study of elotuzumab combined with pomalidomide, one of the IMiDs, and dexamethasone. And these are patients with relapsed refractory myeloma who are refractory to both lenalidomide and a proteasome inhibitor. So pretty refractory relapsed patients. And you will see here the striking benefit of adding elotuzumab to Pomdex, PFS of 10.3 months versus 4.7. And finally, I want to talk about belantamab. Belantamab is the only licensed antibody drug conjugate. Now, this is an antibody to BCMA, which is conjugated to mafodotin, which is a spindle poison. Now, belantamab is interesting because not only does it have FC-mediated activities, because it has an FC-enhanced portion, so it can engage effector cells like for ADCC, but it also has a direct cytotoxic activity by delivering its payload, which is released after proteolysis in the lysosome and kills the myeloma cell by poisoning the reproductive apparatus. So it is, and it is stable in the circulation, and it really only releases its payload once it's in the cell where it is targeted by BCMA. It is licensed after for the treatment of myeloma after 4 prior therapies, so highly advanced myeloma patients. The main toxicities are infusion reactions, corneal events, thrombocytopenia, and anemia. So the corneal events have had a lot of publicity, and indeed we're learning slowly to be able to look out for them and to manage them and to treat them. But on the whole, this is a very well tolerated treatment. And here are the results of the DREAM2 study, on the basis of which belantamab has been licensed. And one of the interesting things about antibody therapy in myeloma is that for patients who respond at all, they have a long progression-free survival and a long duration of response, even if they come off treatment for a long time. And this is illustrated by this graph, where patients who achieved a partial response or minimal response actually enjoyed a long progression-free survival, and strikingly different from the patients who did not respond. So if you look at the PFS for the whole study, it doesn't look great, it's 2.8 months. But actually, this is a drug where if you use it and you find that patients do not respond, you can stop it quickly, whereas if patients do respond, they are likely to gain a good benefit. So that's the end of my talk. And in summary, monoclonal antibodies are a major class of anti-myeloma therapies. The naked antibodies rely largely on FC-mediated mechanisms of action, but anti-CD38 antibodies are now standard of care in treating relapsed refractory myeloma, also incorporated into frontline regimens for newly diagnosed myeloma, including maintenance. The important thing about CD38 antibodies is that they have direct but also indirect immunostimulatory activities that enhance their anti-myeloma efficacy. I've talked about antibody drug conjugates, that these can deliver a toxin to kill myeloma cells, as well as using FC-mediated mechanisms to kill their target. Thank you for listening, and I hope we have time for questions.
Thanks a lot, Kwee. Great presentation.
It's very nice talk. I like it a lot. My question is with respect to the mechanisms of drug resistance of the monoclonal antibodies.
Yes.
Do you think that the mechanism of resistance can be because of the extenuation of the signaling of the receptor, or there are some other mechanisms inside the cells that can create this drug resistance?
Yes. If I had the answers to your question, I would be a millionaire. But it is still very much debated today. There is talk about downregulation of the receptor. I think these are very difficult to do, because when you try to study the surface expression of the receptor, the drug is already binding the receptor, so it's quite difficult to accurately measure the residual expression. But I do believe that truly is downregulation of the CD38 receptor in patients who have been exposed to the drug and who have progressed or are refractory. So I think downregulation of the receptor is certainly one possible mechanism. I would imagine that another mechanism would be related to host immune fitness or activity, like for example, NK cells, but also I think the contribution of myeloid cells to FC-mediated antibody activity is not to be underestimated. So in summary, I think receptor downregulation, but also different arms of the immune response, which might change or become less fit as the disease progresses.
Very good. Thank you very much, Kwee. I think we have to move to the next one. Thanks a lot for joining and for the excellent talk. And now we move to the T cell, the T, more direct T and NK. And for the T based or immune based therapies, T cell based immune therapies, we have Niels van de Donk from the Bridge Universiteit Amsterdam, from the Netherlands. And I think, no, you are already classified in the World Cup, Niels, or not? The Netherlands?
I think we have to conquer to compete to combat. How do you say? We have to defeat Qatar tonight.
Okay. Oh, that's right. That's what I saw.
Yeah,
That's what I saw today. Yeah.
Yeah.
Okay. So let's now focus on T cells, and then we will focus on soccer tonight.
Yeah.
Okay. Thank you very much, Niels.
So after the talk of Dr. Kwee about naked antibodies in myeloma and on antibody drug conjugates, I would like to focus on some new drugs that use, in fact, T cells to kill and eliminate myeloma cells. So I will discuss bispecific antibodies, CAR T cell therapy, and maybe if we have a little bit of time, I will discuss some ongoing efforts that we are currently working on. So I saw a patient in my clinic that was diagnosed in 1992 with multiple myeloma. By then he was treated with melphalan prednisone without response. He was then receiving VAMP chemotherapy, something we don't do anymore, also without response. And he only achieved a partial remission after high-dose melphalan and stem cell transplantation. And then he moved on with an allogeneic stem cell transplant in the same year with a total body irradiation as conditioning therapy. And he also received some interferon maintenance after the transplant. And with that, he achieved a complete remission, which is now persisting for 30 years. So I show you this case to demonstrate that in very refractory, chemo-refractory patients, the allogeneic stem cell transplantation, the T cells of the donor, can be very effective in eradicating the tumor. And this patient is still in a complete remission at this moment. So also after donor lymphocyte infusions, we have seen durable responses, all evidence that there is a strong graft versus myeloma effect that is mediated by donor T cells. Unfortunately, allotransplant donor lymphocyte infusions are complicated by infections and also by graft versus host disease, resulting in a substantial treatment-related mortality. And we need new options for T-cell mediated immunotherapy, which use the patient's own T cells to prevent development of graft versus host disease. And today, I will discuss these two novel forms of T-cell immunotherapy, the bispecifics and the CAR T cells. But before doing that, I want to briefly mention that patients' immune cells, the T cells of myeloma patients, are not very fit because they are exposed for many, many years to high doses of steroids, proteasome inhibitors, and so on. But nonetheless, although the T cells are working very poorly, I think the results that we have now obtained with the novel forms of T-cell immunotherapy are excellent and very promising. So this shows you that the T cells in myeloma are very exhausted, but in the end they are very good killers when you give the patient the right therapies. So here again, the two forms, CAR T-cell therapy and the bispecific antibody on the right, which are both able to eliminate the myeloma cell. So a bispecific antibody has two different arms, as opposed to what a monoclonal antibody has, that is only binding to one antigen, but the bispecific is able to bind to both a myeloma-associated antigen and to CD3 on the T cell, and thereby T cells are redirected to the myeloma cell, and the myeloma cell is subsequently killed by the granzymes and perforins that are released by the T cell. BCMA is a very common target for immunotherapy, for T-cell immunotherapy, and it has as a big advantage that it is highly and quite selectively expressed on malignant plasma cells. And apart from malignant plasma cells, it's also expressed on normal plasma cells, which explains why these patients often develop severe hypogammaglobulinemia, because you also eradicate normal plasma cells with the BCMA targeting bispecifics and CAR T cells. So which bispecifics are we currently using in the clinic in trials and also recently approved teclistamab? Well, there are several BCMA targeting bispecifics at this moment that we have data of. Teclistamab is the one approved in Europe and also recently by the US FDA. And this is based on a phase 2 study showing a 63% response rate, which translated into a progression-free survival of 11 months in heavily pretreated patients. Almost all these patients were triple-class refractory. And in general, these triple-class refractory patients do very poorly. And this can be shown in the locomotion study, where patients with triple-class refractory multiple myeloma were treated with real-world physician's choice of therapy, and there only a 30% response and a progression-free survival of approximately 4 months was seen, which is inferior to the results with teclistamab, which induced a PFS of 11 months and a response rate of 60%, and also substantially higher rate of VGPRs and CRs. Teclistamab has lower activity in patients with extramedullary plasmacytomas, but this is one of my lady patients, where you can see at baseline in November 2020 that she has multiple extramedullary plasmacytomas, amongst others in her muscles, in the leg, but also subcutaneously she had multiple plasmacytomas. And you can see that already in January 21, most of the plasmacytomas have gone. And in July 2022, everything was normalized. And I saw her last week, and she is still 2 years later on in a complete remission without reappearance of the plasmacytomas, while she was very rapidly going through all available other drugs that are currently used, like IMiDs, PIs, CD38s. She was refractory, triple-class refractory within 1 year, in fact, indicating that T-cell immunotherapy can be very effective in patients that are multi-drug refractory. elranatamab, or Elran, is another bispecific, and this agent is also inducing a 60% response rate in heavily pretreated patients, and follow-up is still too short to demonstrate the PFS and median duration of response. And here you see several other bispecifics targeting BCMA, with some differences between them. Some are administered intravenously, some subcutaneously, some have do not need step-up dosing and can be given directly with only a very short monitoring time in the clinic, while others need 2 step-ups and a longer monitoring time in the clinic for CRS, cytokine release syndrome. Then I want to switch to the other form of T-cell immunotherapy, and that is CAR T-cell therapy. Here, patients need to undergo apheresis, whereby the lymphocytes in this case are obtained and sent to the laboratory. And in the laboratory, the CAR T cells are produced by introducing a chimeric antigen receptor into the T cell. And this CAR T cell is able to recognize, in this cartoon, BCMA, and that again results in the elimination of the tumor cell. So here's some key data. Ide-cel was evaluated in heavily pretreated disease in a KARMA study, where we see in all the patients a 73% response rate and a median PFS of 8 months. So very similar to the data that I showed you with the bispecifics. And this study led to its FDA and EMA approval. Cilta-cel is another CAR T-cell product which can bind BCMA via 2 antigen binding domains. So there's a higher affinity binding, and that may explain why we here have a higher response rate, 97%, with also a higher CR rate of 82%. And this may explain why Cilta-cel has a better response duration and PFS than what we see with Ide-cel, because here at 27 months, the PFS rate is 55% in all the patients. And of course, it's better if you achieve a complete remission or when you achieve sustained MRD negativity. That's the upper lines. Cilta-cel is also evaluated in earlier lines of therapy, and here just an example from the cohort B of the CARTITUDE-2 study, in which Cilta-cel was given to patients who relapsed within 1 year after transplant. And this is, of course, a very poor group of patients. If you relapse within 1 year after transplant, survival is typically very short. Nonetheless, Cilta-cel induced a 100% response rate with a CR rate of 90%, and at a median follow-up of 13 months, PFS was in the order of 90%, which is, of course, much better than it was after transplant. So Cilta-cel is better in terms of efficacy than bispecifics. Ide-cel has quite similar efficacy profile as compared to the bispecifics. In terms of safety, we see similar toxicity profile. We see CRS, we see some neurotoxicity, but this is typically of lower grade with the bispecifics. And of course, we see infections, whereby ocular toxicity is only seen with the BCMA targeting antibody drug conjugates, as Kwee, Yong already discussed, but not with the T-cell immunotherapies. Infections are also seen with the bispecifics and with the CAR T-cells, caused by hypogammaglobulinemia, caused by neutropenia, and maybe also T-cell exhaustion with the bispecifics. And what you can see here is that the infection rate, especially grade 3 or higher infection rate, seems to be higher with the bispecifics than with the CAR T cells. And this may be related to the fact that you have to continue, at this moment at least, bispecific antibody treatment until progression. And we should do studies, in fact, to study fixed duration treatment, to lower infectious rate, to lower the costs, and maybe in the end, this also translates to a better efficacy profile. So we have very effective novel T-cell immunotherapies, and choice of BCMA modality, if you have the opportunity to choose, which is not always possible, depends on product characteristics, of course, availability and logistics, patient-related features like cardiopulmonary status, patient's preferences, prior BCMA therapy, and also disease-related features like proliferation rate of the tumor. Because patients that have very rapidly progressive disease, no good options to bridge, are better off with an off-the-shelf therapy such as a bispecific, or maybe in the future, these patients may also benefit from allogeneic CAR T cells that can also be given to the patient off the shelf. And several studies are now evaluating allogeneic CAR T cells targeting SLAMF7, BCMA, or other myeloma-associated antigens. So what about the next steps? What are currently ongoing studies studying? Well, there are studies looking at novel targets for therapy. Combination therapy, especially with the bispecifics, is being evaluated. And all these compounds, because of the high efficacy in end-stage disease, are moving to early lines of therapy, including patients with newly diagnosed disease. So here you see talquetamab. This is a GPRC5D targeting bispecific, which induces 70% response rate with at the two different recommended phase 2 doses. And similar to the BCMA bispecifics, we see cytokine release syndrome, a very low rate of neurotoxicity. But here we see some very specific on-target off-tumor toxicities related to expression of GPRC5D in the cells that produce hard keratin, such as the cells that produce the nails, or produce hair, or produce parts of the donk, the papillae. So that may explain why these patients sometimes develop loss of taste, weight loss, skin-related adverse events, and also loss of the nails. Sovostamab is another bispecific that targets FcRH5, which is highly expressed on myeloma cells, and at the higher dose levels, there is a 60% response rate. So we also have CAR T cells that target other antigens. And recently presented in the New England Journal of Medicine is the first report on the efficacy of GPRC5D targeting CAR T cells in heavily pretreated patients, including patients that had already been exposed to BCMA CAR T cells. And we see promising response rates, but also a new adverse event. And that new adverse event was a sort of cerebellar disorder. And this may be related to the fact that GPRC5D expression was also found in the brain, especially in the inferior olivary nucleus, which is transferring signals between cerebellum and the spinal cord, if I remember correctly. Then very briefly, something on combination therapies. We are studying combination therapies to deepen response and also to improve response duration. We are investigating the combination of a bispecific with an IMiD or with a CELMoD, because IMiDs and CELMoDs can improve T cell fitness. And we are also studying bispecifics in combination with CD38 antibodies, because they eliminate Tregs, and Tregs have been shown to confer resistance to bispecific antibodies. And T cell fitness is also better in earlier lines of therapy. And that's why, for example, in EMN30, Majestic 4, we are investigating teclistamab plus len after transplant in newly diagnosed myeloma patients in order to get a longer progression-free survival, a longer overall survival, as compared to what we achieve today with lenalidomide maintenance. And elranatamab is also tested as a maintenance drug in the Magnetism 7 study. So this is my conclusion. We have booked enormous progress in multiple myeloma treatment with the introduction of transplant, IMiDs, proteasome inhibitors, the naked antibodies, and more recently, T cell immunotherapies are also really transforming myeloma treatment. Both CAR T cells and bispecific antibodies have shown dramatic efficacy in triple-class myeloma, and I discussed when you choose a CAR T cell product over a bispecific or vice versa. And we are trying to overcome resistance by smart combinations, and also by using these drugs in early lines of therapy where T cell function is better preserved than in end-stage myeloma. Thank you for your attention.
Thank you very much, Niels. Excellent overview of these T-based cells and targets. And well, just one question I have for you is why? Because here the targets are BCMA, GPRC5D, FcRH5. Why don't we have a good CD38 antibody, bispecific antibody, or a CD38 CAR-T? Why this is just for naked antibodies?
Yeah, that's a good question. So CD38 is highly expressed on myeloma cells, but also on normal plasma cells, on NK cells, on T cells. It's expressed in the eye, in the retina. It's expressed in the kidney. It's expressed on smooth muscles in the lung. So it may be that the high avidity binding to CD38 will lead to too much on-target off-tumor toxicities. So in our lab, we developed CAR T cells, in fact, that bound to CD38 with lower affinity, and then you can kill the myeloma cells with high expression and spare the normal tissues with lower expression of CD38. But of course, if you lower affinity to CD38, this may also lead to the rapid development of variants that escape from the immunotherapy by lowering the expression levels. And this happens very quickly with CD38, as we know from daratumumab therapy. So I think we have to be careful with CD38. In fact, there was an Amgen compound that was targeting CD38. Development stopped because of a business decision, but maybe also toxicity related. I don't know. No data were disclosed, and I did not work with that compound. And Sanofi is also developing a trispecific targeting CD38. So we will know more in the future of whether CD38 is a good target or not. Okay, perfect. Thank you very much. And so now we have to move to the last part. Thanks, Niels. Yeah, and now we move to the last talk before the keynote lecture, which is by Michael O'Dwyer, that has been with us for the whole 2 days, really, here. And he is an expert on NK-based immune therapies. And he will speak on how this is, what is the development of this type of therapies using not T, but NK cells in multiple myeloma. So thank you very much, Michael.
Just to thank you very much, Enrique, for inviting me to participate in the meeting. I've enjoyed the last couple of days and very much. And what I'm going to do is try and take you through some of the new NK approaches that are in early development. And so this will contain primarily preclinical data. And this is my disclosure. I will be mentioning some data that relate to ONK therapeutics, of which I'm currently the Chief Scientific Officer. So NK cells, just by way of introduction, are CD56 positive, CD3 negative lymphoid cells, or innate lymphoid cells, and they can respond to virally infected or cancer cells with a variety of effector functions, mainly cell killing and production of pro-inflammatory cytokines. And they have a series of germline encoded activating and inhibitory receptors, and it's really the activation status of the NK cells via the inputs through these receptors that leads to a delicate balance that determines whether cells will be activated or inhibited and commit to killing a target cell. And one means of doing this is, for example, loss of MHC class 1 on tumor cells, that this leads to reduced inhibition of NK cells via their KIR inhibitory receptors. And another mechanism is increased recognition of stress-induced ligands on the surface of a tumor cell that leads to activation via the activating receptors. But once an NK cell commits to killing a target cell, it releases perforin and granzyme, and this leads to cell lysis. And they can also kill via the death receptor pathway by inducing expression of Fas ligand or trail. And finally, release of cytokines such as interferon gamma and TNF alpha play a very important role in promoting a subsequent adaptive immune response, so leading to clonal T cell proliferation. And finally, in the presence of antibodies, engagement of CD16 leads to strong activation, which can override other inhibitory inputs, leading to antibody-dependent cellular cytotoxicity. Now, NK cells have been attracting increasing attention in recent years as a potential source for treatment of cancer. And for some years, though, it has been known that NK cells are capable of innate recognition of myeloma cells via their activating receptors. And in this trial reported by Nina Shah, now going back about 4 years, the administration of unmodified cord-derived NK cells followed by autologous stem cell, or following rather autologous stem cell transplantation, generated promising preliminary data supporting the safety and potential efficacy of allogeneic NK cell transfer. And these cells, I don't believe, are matched in any particular way. Now, apart from cord blood, there are a number of potential sources of NK cells for adoptive cell transfer. And these include peripheral blood, progenitors, induced pluripotent stem cells, and of course, cell lines. And these cells can be genetically modified to include transgenes such as a CAR, or undergo gene editing before expansion into large numbers using cytokines and feeder cells, which provide important co-stimulatory signals. And these cells can then be cryopreserved before administration following lymphodepletion. And it's important just to note that a source of IL-2 or IL-15 is essential for proper in vivo expansion and persistence. Now, much greater benefit can be obtained when NK cells are combined with monoclonal antibodies, and several companies are developing off-the-shelf CD38 knockout NK cells that can be combined with CD38 antibodies, such as daratumumab, without fratricide or self-killing, which would otherwise be the case. And in this example from Fate Therapeutics, knockout of CD38 in a pluripotent stem cell, shown on the top left, enables the differentiation of clonal iPS-derived NK cells lacking CD38. And since iPS-derived NK cells express very little CD16, these cells must also be engineered to express CD16 to enable ADCC. And as shown on the top right, the resulting NK cells have strong expression of CD16, but lack CD38 expression. And on the bottom left, in the presence of daratumumab, cells lacking CD38 and or CD16 are resistant to fratricide, unlike peripheral blood NK cells or CD16 expressing iNK cells expressing CD38. And then on the bottom right, it just shows that these doubly modified cells have superior anti-myeloma activity. Now, these cells are then further engineered to express an IL-15 receptor fusion, enabling cytokine-independent growth designed to enhance in vivo persistence. As shown here, compared to either iNK cells or daratumumab alone, the combination of iNK cells with dara was much more effective in controlling tumor burden in this MM1S NSG model. And this product, FT538, is now in the clinic for patients with both multiple myeloma and AML, and initial phase 1 data will be presented at this coming ASH. Using delivery of Cas9 RMP complexes into peripheral blood-derived NK cells, Dean Lee's group at Ohio State University achieved efficient knockout of CD38, resulting in enhanced killing of primary myeloma cells, as shown on the top left, and improved in vivo persistence, as shown on the right, in the presence of daratumumab. And using a seahorse analysis that's shown on the bottom left, they also demonstrated that CD38 knockout in NK cells leads to an enhanced metabolic profile with enhanced oxidative phosphorylation and glycolysis, though that's not shown here. Now, that's because CD38 is an NADase, and knockout leads to enhanced availability of NAD, thereby improving cellular metabolism and increasing resistance to oxidative stress. So interestingly, CD38 knockout may confer resistance to allorejection in the presence of daratumumab. So this data is from a presentation at last year's ASH meeting from Fate Therapeutics. In the mixed lymphocyte reactions, daratumumab was able to eliminate alloreactive T and NK cells and provided more protection to allogeneic CD38 knockout NK cells than knockout of beta-2 microglobulin alone, which is often used as a means of overcoming T-cell rejection. And Fate are now pursuing this approach as a potential alternative to standard lymphodepletion. So what then about CAR NK cells? Well, allogeneic CAR NK cells could have many advantages over existing CAR T cell therapies. And unlike allogeneic T cells, which Niels mentioned, NK cells do not cause graft versus host disease and so don't require a lot of editing to enable administration of an allogeneic product. Furthermore, NK cells can recognize tumors in multiple different ways, potentially reducing the risk of failure due to antigen escape. NK cells are well tolerated with minimal risk of inducing CRS or ICANS toxicity. And finally, off-the-shelf NK cell therapies are immediately available, unlike autologous CAR T cells, which can, of course, take weeks to produce. And batch manufacturing means that many patients can be treated by a single donor, markedly reducing cost. So are there CAR NK cell products then in development for multiple myeloma? Well, building on the FT538 product, Fate have added in a BCMA CAR into their FT576 product as shown. This is promising in vivo activity in the MM1S model with superior in vivo activity compared to non-modified PBNK cells. And following infusion, these NK cells also demonstrated better in vivo persistence compared to peripheral blood NK cells in these mice. However, when FT576 was combined with daratumumab and or a gamma secretase inhibitor to increase BCMA expression, there was much greater tumor clearance. And this product is in fact now in phase 1 trials in relapsed refractory multiple myeloma with and without daratumumab, and early data are expected to be presented at the coming ASH meeting. Now, with an eye perhaps on the post-BCMA space, Janssen and Fate are co-developing FT555, a CAR similar to FT576, with the exception that instead of a BCMA CAR, it targets GPRC5D. Now, these data are taken from an abstract to be presented at ASH, and in an in vivo MM1S model, the FT555 product showed promising anti-myeloma activity, which was superior to a CAR T, though wasn't specified against what target, with control of myeloma progression for up to 42 days and increased survival. And as before, the efficacy could be greatly improved by the addition of daratumumab. Now, maybe taking off, or up rather, where Niels left off, ONK Therapeutics is developing a CD38 CAR NK for the post-BCMA space and believe that CD38 may represent a good target in this setting. Now, I mean, this may be just an opinion, but progression on daratumumab may be primarily due to a lack of functional innate effector cells, including NK cells and M1 macrophages, as well as T cell exhaustion, rather than loss of CD38 per se. The expression, of course, which recovers within 3 to 6 months following discontinuation of CD38 antibodies, and which is depleted both in responders and non-responders. However, beyond a direct anti-myeloma effect, targeting CD38, as we've heard, may have the potential for beneficial immune modulatory effects, and as shown earlier, may even be able to eliminate alloreactive T and NK cells, preventing rejection, which is important in an allogeneic product. However, targeting of CD38 with a high affinity CD38 CAR, could induce on-target off-tumor toxicity, as mentioned by Niels, and this, of course, was seen in the preclinical studies at VUMC with high-affinity CD38 CAR T cells. But our strategy, therefore, is to use an optimized affinity CD38 CAR to mitigate this risk, and indeed, this CAR originally was developed at VUMC. So in collaboration with our colleagues at VUMC in Amsterdam, we have shown that an optimized affinity CD38 CAR in the context of NK cells induces potent cytotoxicity of tumor cells from patients with multiple myeloma, and this includes patients who were refractory to daratumumab. And indeed, there was no evidence of increased on-target off-tumor toxicity in myeloid progenitors, NK cells, or T cells compared to mock control cells, suggesting indeed a favorable safety profile. However, interestingly, there was increased killing of CD38 positive Tregs, again suggesting the potential for an immune modulatory effect. So we then went on to confirm the in vivo activity of our CD38 CAR using cryopreserved cord blood, which of course is important for an off-the-shelf approach. And these NK cells were engineered to express the CAR using the TC Buster transposase system, and they were tested in NSG mice inoculated with MM1S. And as shown, the CD38 CAR significantly reduced tumor burden compared to either PBS control or unmodified NK cells, and this resulted in a significant survival advantage for the CAR expressing NK cells. Of course, beyond the introduction of a CAR, there are several potential engineering strategies, as shown on the slide, that could be employed to optimize NK cell function. And of particular importance are strategies to maximize NK cell metabolic health and persistence and overcome exhaustion. Now, indeed, there's good evidence that NK cells in patients with multiple myeloma have hallmarks of exhaustion, one of which is increased expression of the key intracellular checkpoint CISH. So CISH is a member of the suppressor of cytokine signaling family and negatively regulates IL-2 and IL-15 signaling, impacting on activation, proliferation, and cellular metabolism. And several groups, including Katie Rizvani's group, have independently confirmed that CISH knockout lowers the activation threshold of NK cells, making them much more sensitive to cytokines, improving their metabolic fitness, and ultimately resulting in enhanced anti-tumor activity and improved persistence. So using CRISPR-Cas9, we're routinely able to knock out both CD38 and CISH at the protein level, which of course is confirmed by sequencing. A knockout of CISH greatly enhances killing by CD38 CAR NK cells and makes them less susceptible to exhaustion, with significantly improved tumor control in an extended co-culture assay shown in the center, in which NK cells are repeatedly challenged with fresh tumor, shown by the black arrows, which is basically a form of a stress test, testing the endurance of NK cells and is more reflective of how they should perform in vivo. And finally, the introduction of CISH knockout greatly enhances its secretion of cytokines, such as interferon gamma, which is important for an adaptive response. So in our next in vivo experiment, we wish to see whether the added benefit of CISH knockout in the CD38 CAR would lead to enhanced in vivo response, and also whether there was any evidence of a dose response. And in the interest of time, just wish to say that treatment with the CD38 CAR NK cells in which CISH was knocked out led to a small but nevertheless significantly greater reduction in tumor burden compared to treatment with the CD38 CAR alone. And at day 30, there was a 99.8% tumor growth inhibition in these mice treated with these cells, shown at the pink curve at the bottom. And in the combined groups, there was a significant survival advantage in favor of the CISH knockout CD38 CAR NK cells. All of these studies were done with electroporated cells, and since then we've moved on to use LNP edited cells as lipid nanoparticle edited NK cells, which have the advantage of resulting in much greater NK cell health, and in vivo studies are currently ongoing, and we'll report on this in the near future. But basically what this shows is the overview of our manufacturing process, and the whole process takes about 3 weeks, following which CAR NK cells are harvested and cryopreserved for future use. And depending on the final dose, it's possible to generate hundreds to thousands of therapeutic doses literally from a single cord. Now, in the interest of time, I'm not going to go through NK engagers, but basically just to conclude that there are many exciting NK-based therapies in development for myeloma with engineered allogeneic NK cells and engagers entering the clinic. Clinical data is awaited with great interest. And of course, products targeting other targets other than CD38 are needed, and engineering NK cells beyond the introduction of a CAR may be necessary to achieve durable responses. And finally, there are open questions remaining regarding the optimal source of NK cells, the frequency and schedule of treatment, and the optimal method of lymphodepletion. So I'll stop there. Thank you very much.
Thanks a lot, Michael, for the excellent presentation. Absolutely. So I think this field of the NK have a great promise in the future for multiple myeloma. So thank you very much, Michael. And now we move to the last keynote lecture. Here is my pleasure to introduce Ken Anderson, Dr. Kenneth Anderson. Yesterday we had the opportunity to have Jesus and Miguel speaking about the road to the cure of myeloma. And today we have Dr. Anderson. That is, well, this, I think in my case, these are my two fathers in multiple myeloma, I would say, Jesus and Ken Anderson. I think they are now the fathers of all the myeloma community. Dr. Anderson is the director of the Jeroen Lipper Multiple Myeloma Center in Boston, in Dana-Farber Cancer Institute. And as I said, he's one of the leaders in multiple myeloma, in international leaders, really one of the two international leaders in multiple myeloma. He will speak about In Search of the Achilles Heel of Multiple Myeloma. So thank you very much, Ken, for being with us.
Thank you very much, Enrique, for inviting me and this wonderful session and really cutting edge science. Very, very impressive. I've been honored to just talk to at the end here about new targets or Achilles heels in multiple myeloma. Here are my conflicts of interest. I always like to start with this because historically, we now have 16 new classes of medicines, which have, you all have heard about and you know very well, which have been used alone and in combination in 31 different approved treatments. This has resulted in myeloma being a chronic illness in many patients. And in my myeloma lifetime, we've seen the development of transplants since the 1980s, the novel drugs, IMiDs, proteasome inhibitors, antibodies, since around 2000. And now, as you've heard so beautifully, Michael and others, we're in an immune revolution. Now, I want to just mention that we've been thinking about the tumor and the microenvironment for 20 years or more. This just is an old slide that shows you that when bortezomib was approved, it was targeting the proteasome, primarily the chymotryptic activity. But even in the early studies, some of which people on this Zoom carried out, actually, there were many effects on the tumor cell and in the microenvironment, including inhibiting adhesion by regulating adhesion molecules on the tumor and the stroma, and also effect on bone biology in terms of the osteoclast, for example. Similarly, when the IMiDs came about over 20 years ago now, this is one of the initial diagrams that actually Nupur Raj actually proposed years ago, where there was direct killing, and there was also in the microenvironment, decreased adhesion, decreased cytokines, decreased angiogenesis, upregulation of NK and NKT cells, cytolytic T cells, and downregulation of regulatory T cells. So what am I going to do now is just tell you about what we're up to now that's really extending that work, always thinking about how can we use mechanisms that are naturally present, binding to ECMs, binding to stromal cells that confer growth survival drug resistance and immunosuppression. How can we target those with Achilles heels? And then tell you a little bit about some of the new recognized impacts or sequelae of the drugs that we've been using for years. A couple quick examples of new targets, one in the tumor, one in the microenvironment, and one induced when the tumor and microenvironment interact. A little bit about what I think about in terms of targeted therapy in myeloma, which honestly, due to the complexity of our disease, has really not been very possible, but may be useful, especially at the time of relapse. And I'll just expand a little bit and try to cover some different points that were mentioned than for the CAR-T or NK talks that were so beautiful just a minute ago. So firstly, what we're doing now in terms of the microenvironment is adhering tumor cells to stroma as shown on this slide, and now doing RNA-seq and attack-seq. And what we're trying to define is what are the differences in chromatin accessibility and consequent gene expression. And it turns out there are strong changes in chromatin accessibility, which are associated with gene transcription changes. And on the left-hand side here is the genes that are going up that are more favorable and the genes going down that are more unfavorable. And Dr. Bender, who worked with us from the Mayo Clinic, had an adverse stromal interaction index. And in fact, when he calculated this based on the genes up and down, and then looked at it with a variety of clinical databases as shown on the right, there was a strong correlation. So this is not just looking at the tumor or the microenvironment, it's looking at the consequences of the interaction. And I just put in one slide here. This on the left are plasma cells from a patient with malignant ascites and pleural effusion. On the right, circulating plasma cells. But these are gene signatures that were induced when myeloma cells bound to stroma. So it suggests when tumor binds to stroma, there is induction, at least in a small subset of cells, of metastatic potential myeloma induced by the microenvironment. All this says to me is we really need to start thinking about profiling patients from diagnosis onward in terms of the tumor and the microenvironment. Now, Anna Maria Gula has looked at something called immunogenic cell death that you all know well, and used bortezomib, which was originally inhibiting the immunoproteasome, but here it's stimulating an immune reaction. You have on the upper left, you have bortezomib inducing calreticulum, an eat me signal in a dose-dependent way on the cell surface. Number two, there's uptake by dendritic cells as shown on the upper right. There's an immune response as shown in the lower right, which lyses myeloma cells. And the question is, how is this actually happening? And there are likely different mechanisms triggered by different drugs, but in our studies with bortezomib, there's genomic instability induced and IRF3 TBK there is genomic instability and CGAS sting TBK IRF3 signaling and a type 1 interferon response. And that's shown on a Western blot up in the upper right. And in fact, there's an ICD signature that Anna could identify as a consequence of bortezomib treatment. And in the left here, in the red, those patients who had an ICD signature before treatment who participated in our RVD with or without transplant study did the best. And you can see in the red here, their overall survival was superior. So what Anna has gone on to do, and she's going to report this at ASH, so I'll just mention it very quickly. She went on and looked at the patients in our IFM-DFCI study who did very well versus those who didn't. And she looked at the gene signature of ICD, and she looked for the overlap as shown in this cartoon. And she found a gene and a protein called GAPRAB. So I'm just going to tell you in one cartoon, what her initial study showed here was that bortezomib, killing the myeloma cell directly by inhibiting the proteasome, also induced an immunogenic cell death by mobilization of calreticulum. It turns out GAPRAB is required for this chaperoning of calreticulum to the cell surface and the consequent induction of a myeloma selective response. In the absence of GAPRAB in the lower left here, the same bortezomib treatment does not result in calreticulum on the cell surface. Rather, it's sequestered in the mitochondria and there is no immune response. So why am I saying this? Because GAPRAB is on chromosome 17p. And so, as you know only too well, high-risk myeloma and many other blood cancers and more generally solid tumors as well with p53 deletion are high risk. It suggests if we could restore immunogenic cell death, we could potentially overcome high risk, and which is what Anna will present and talk about in her studies. Another newly appreciated effect, or maybe one that we can exploit, was derived from our same study, RVD with or without transplant, that you know that was reported by Paul Richardson this summer. And he reported there's about a 20-month benefit when you added transplant to RVD in terms of PFS, but no advantage in terms of OS. The only reason I wanted to mention it here quickly is we've had a chance to follow these patients over time, and unfortunately, some have relapsed. There are many more mutations in those patients who relapse after melphalan treatment, as shown here in the blue, versus this in the green who relapse after RVD. But what's more important is what's shown here. These are neoantigens that are expressed more commonly after high-dose melphalan treatment. This may at least correlate or be associated with the responsiveness that we all see with the IMiD maintenance post-transplantation. Now, you know the IMiDs, I showed you the cartoon that was 20 years old, but we learned after 15 years using the IMiDs as a community that they bound to cereblon and induced Ikaros 1 and 3 degradation, both in tumor cells on the left and in immune cells on the right. But as you know, this has been exploited, and I will just give you one further example in a minute. The IMiDs have more potent, as you know, the cell mods, and CFT 7455, but they're what's called molecular glues. So when they bind to cereblon, they change the affinity and stability of binding to Icaros 1 and 3. And the point is here, they're enhancing the substrate degradation by this so-called molecular glue function. On the right here is a different exploitation of this cereblon mechanism by functional degradation, where in fact you have binding to cereblon on the right, binding to a target protein on the left, and ubiquitin-mediated degradation of a protein of interest. And I just want to mention BRD9 in multiple myeloma as a potential new target. At the depth map, BRD9 is actually a dependency for myeloma cell growth. In our studies, we showed that it was more common in myeloma than in healthy donors. It has an adverse prognostic impact if you knock it down with SH, or you use a BRD9 degrader here in the lower left. You in fact inhibit myeloma patient cells growth, and you inhibit myeloma cell growth in vivo. And without going into great detail in the interest of time, we went on to show that this actually is associated with decrease in ribosome biogenesis, as shown here. There's a very strong correlation between ribosome biogenesis and BRD9 expression, and a ribosome biogenesis signature actually correlates with response to BRD9. I tell you all this because there are BRD9 degraders, both IV, but in particular, an oral BRD9 degrader in clinical trials at present, which we hope can be tested in myeloma based on these studies. So that's a new target with a new mechanism degradation, BRD9 in the tumor. What about the microenvironment? Well, we found that in the bone marrow plasma patients with myeloma, there's a rich source of proline. Why is that relevant? Because proline here, under the consequences of an enzyme called EPRS, which is glutaminyl-prolyl tRNA synthetase, can actually charge transfer RNA and augment protein translation. Consequently, or conversely, we have made, with our collaborators, a prototype inhibitor of this process. And if you block this, you block protein translation, you induce an amino acid starvation response, cell cycle arrest, and in vivo growth inhibition. So I'll just show you this in a minute. This is the enzyme here, EPRS, that's expressed in myeloma. It actually has an adverse prognostic impact. As you go from healthy donors to relapse refractory myeloma, there's more expression. And again, it has an adverse outcome on survival. And if you knock it down, you inhibit myeloma cell growth. Why is this important? The new inhibitor that we call NCP26 was made so that it is not competitive. That is, you can use this in the presence of proline to inhibit myeloma cell growth, to inhibit myeloma patient cells, and in vivo. And on the left, if you just focus here for a minute, with increasing concentrations of proline, this new inhibitor still has its effect, whereas prior inhibitors actually are competed out. So this is a way of potentially a metabolic process, if you will, with proline, but inhibiting something in the microenvironment. And then this is the consequence one, where you look at the consequence in this example of an interaction between a plasmacytoid dendritic cell and a myeloma cell, which is shown on the right to induce CD73 on the cell surface of both the myeloma cell and the accessory plasmacytoid dendritic cell. And what is CD73? It's a cell surface enzyme. It converts AMP to adenosine. And you heard just a minute ago about adenosine being immunosuppressive for both CD8 cytolytic T cells and NK cells. And we've used an antibody and an oral inhibitor to block CD73. When you do this, you can in fact restore myeloma cell killing. This is killing of an autologous myeloma cells, autologous effector cells in the presence or absence of antibody to CD73. You can decrease viability in a statistically significant way. I present this just because it's an interaction example, but There's clinical trials ongoing, and this will be presented at the upcoming ASH as well. Now, we, as you know, in my opinion anyway, haven't been very effective at targeted therapies in multiple myeloma. Perhaps the one example that is the exception here, Larry Boyce had a beautiful talk a bit ago, is the BCL2 example where gene and protein high expressing myeloma cells respond to venetoclax alone or in combination with proteasome inhibitor on the left here in terms of their progression-free survival, with a trend here in overall survival. But short of that one example, I think we haven't really had a lot of success, or at least not as much as we would like. So what we carried out was this CRISPR-9 screen. And the concept here is, can we use targeted therapies, if we're not going to use them as initial treatment, can we use them potentially to restore or overcome resistance to some of the drugs we know are effective already? So this was an example of pomalidomide, or the IMiDs. We carried out a CRISPR-Cas9 screen. We came up with a gene and protein called TRAF2. If you deplete TRAF2, you get complete resistance to pomalidomide. And in the lower left here, when you knock out TRAF2, you actually get activation of non-canonical NF-kappa B and ERK-MEK signaling. What's important here is on the right, if you add in an ERK-MEK inhibitor, you can restore sensitivity to lenalidomide in vitro in the top here in a dose-dependent way, and in vivo as well. Now, I started by saying I've been obsessed with the microenvironment for a long time. And so what does this have relevance in the microenvironment? Well, it turns out if you add stromal cell supernatant to a myeloma cell line, you can confer resistance to pomalidomide here. And you also downregulate TRAF2, and you also activate phosphorylate ERK as shown here. Same thing I just mentioned for the intracellular mechanism, so it's here for the microenvironment mechanism. If you add in a MEK-ERK inhibitor in a dose-dependent way, you can kill myeloma cells here, even in the presence of supernatant, or on the right, even in the presence of IL-6. So maybe we can use ERK-MEK inhibitors in this example to restore resistance to the IMiDs. You heard a wonderful talk from Kwee about CD38 monoclonal antibodies. And again, here, the same microenvironment example. This is 4 myeloma cell lines on the left in the presence or absence of bone marrow supernatant. And in each of them, CD38 is downregulated in the presence of supernatant. And it's a transcriptional downregulation as shown on the right, mediated by either stroma or interleukin-6. So in recent studies, we actually said, what is the mechanism? And it's a STAT3, STAT1 activation mediated mechanism of downregulation of CD38. If you add in ruxolitinib, the JAK inhibitor, in a dose-dependent way, you can downregulate the STAT signaling as shown here. And importantly, you can, on the upper right here, upregulate CD38 expression, even in the presence of supernatant. And on the lower right, you can upregulate CD38 ADCC, even in the presence of supernatant. So we don't often think about this, but you know what happens with the CD38 target in this example in patients that we are now treating. And this is very recent data that is just one slide. It's going to be presented also at oral session at ASH, so I'm going to be very descriptive here. But in any event, we did a screen and we found that KDM6A, a CRISPR-Cas9 screen, also regulates CD38 expression. That's shown up here in the upper left, CD38 going down in the knockout. We also found, surprisingly, CD48 was also markedly downregulated in the KDM6A knockout. And this shows you the methylation here at the promoter of both CD38 and CD48. And why I'm mentioning it here today, an EZH2 inhibitor, even in the presence of the knockdown of KDM6A, could restore CD38 and 48 and restore lysis even in the knockout cells. So the cartoon is really, and he'll present a lot of mechanistic data, which I did not, But the purpose here is that KDM6A is regulating the expression of CD38, CD48 on myeloma. As I'm sure Michael can tell you more than I can, CD38 binds to 2B4 on NK cells, and it's an activation signal. So the point here is that if you inhibited KDM6A or restored with an EZH2 this mechanism, upregulated these two antigens, you could upregulate, in this example, daratumumab-mediated lysis, but by upregulating CD48, this mechanism may be effective for activating or upregulating ADCC more generally. Now, you heard all about CAR T cells, and I'm not going to say anything except try to do something new. You know that there's 2 FDA approved on the right, and you know all this data by heart, so I'm not going to tell you again. But why I wanted to just mention it is I think the future of the CAR T is going to be a little bit different. It's hugely exciting, but I honestly think it has very many practical limitations. The idea that you have to get the patient and coordinate it and send the cells away for several weeks and they come back, and it can happen, but it's very logistically challenging. In this concept, we have a construct that can be made literally overnight. And we give back, instead of expanding the cells ex vivo, we give back the cells at small numbers. So on the left here, it's 2.5 million, 5 million, up to 15 million cells. And on the right, these cells expand in vivo. And they are early lineage memory cells that expand. And we have some very prolonged responses. And again, this will be presented by Dr. Sperling and updated at this year's ASH. But the concept is this could be very readily done. And if you think about it, the expansion in the context of the antigen target in vivo makes a lot of sense. It may be that we have to give 450 million or large numbers of cells, in part at least because we expand ex vivo and we have exhausted, figuratively and literally, T cells that we're giving back. We've also been preclinically experimenting with RNA CAR T cells. And I always point out panel B here, where we've transfected in the RNA CAR. And the issue is it's only transcribed in the in vitro or in our animal models for about 9 or 12 days, and kills myeloma cell lines, and it kills myeloma patient cells in the presence or absence of stroma, and it kills autologous myeloma cells with autologous, entirely autologous system. There's already ongoing clinical trial, even in newly diagnosed multiple myeloma. And the concept here might be, with mRNA CARs, you might have less toxicity and you might be able to use repeated dosing, just as we use with targeted therapies in cycles of therapy at the present time. You already heard beautifully about allogeneic and NK cells based therapies, and I'll just mention this one concept. At least my view is that this still has appeal, because I think with the gene editing, people have really pretty much overcome any graft versus host disease related to infusion. The issue comes still of rejection by the patient of the allogeneic Ts and the CAR Ts. And you can do this with immunosuppressive therapy and also other strategies whereby you could abrogate a rejection response should it happen. You know very well the CD52 idea, where you could treat with a CD52 antibody, having edited CD52 off of the CAR T cell in the allogeneic setting. And I'm not even going to talk about this for a second because Michael gave such a beautiful talk, but I'm actually quite positive. I wanted to put it in because I really like the concept. I think it's so, you know, you talked about cord blood, and you can get lots of doses from one cord blood, and it's off the shelf. You can use it repeatedly. You don't have to type. It has incredibly, I believe, a great appeal. And I'm extremely excited that NK CAR and also NK T cell or engagers are going forward as well. Now, we do need other targets. And I will just cite this, you know it, I think. This is actually my patient for what it's worth. She was the first patient on the BB2121 protocol. And on the left, the blue is the monoclonal protein, the green is the light chain. And she got the BB212 and she had a wonderful response, multiply relapsed myeloma, went into MRD negative response, but then relapsed. Both the M protein and light chain came back. And on the right of the BCMA levels, which were high in the blue at the time of her first CAR T and low at the time of her second CAR T in the red, to which she did not respond. And it turns out that BCMA is on chromosome 16p. And it turns out that if you look at high-risk myeloma, 17p deletion, 16p is concomitantly deleted quite frequently. In our experience, maybe 30%, even 40% of the time. So I think in the future, we're going to, practically speaking, for treatment, we probably need to start thinking about examining 16p expression. And secondly, I think we're going to need, as you've heard beautifully, other targets. You already heard this, but this is from Eric Smith, who's now at our institution when he was at Memorial Sloan Kettering, the GPRC5D story. But the only point I'll make is at the bottom that after BCMA relapse, you have responses to this GPRC5D CAR T cell. Very exciting, early days, but nonetheless, very effective agent. We like this concept a lot. It's not in the clinic yet, but we're moving along. It's called a binary activated T cell with chimeric antigen receptor, BAT CAR. And you have the typical CAR construct on the left. In the middle, you have the BAT CAR. And the same CAR construct, except the SCFV has a label on it, say fluorescein. And what you could do is give daratumumab or a CD38 antibody labeled with fluorescein, and then you come back and you give the BAT CAR, which then will bind only where fluorescein has already labeled the myeloma and activate the CAR T cell. Hopefully in so doing, you'll have very nice therapeutic window. You could use more than one antigens at a time, use elotuzumab and daratumumab and both labeled with a marker, and then activate both CAR T and maybe prevent antigen escape and resistance. On the right is shown, this is daratumumab in an in vitro experiment. I mention it only because it's low effector T cell, it's a short duration, it's low amounts of antibodies and effector cells, so it should be therapeutically very effective. And you could use this with anybody's antibody in myeloma or more broadly in solid tumors for that matter. We now have switches where you can augment, upregulate or downregulate these BAT CAR activities as well. You heard beautifully about the bispecifics, and you know that teclistamab is the one that's FDA approved, both now, first it was EMA and finally FDA approved recently. But I think the future is going to be combinations. And so this is the GPRC5D BiTE with daratumumab. You all know the construct here, but the idea is that the GPRC5D BiTE, just like the GPRC5D CAR, works when BCMA-related treatments don't anymore, about 30% of the time in this initial experience. And if you add in the CD38 antibody, 55% of patients whose myeloma had relapsed from BCMA did respond to the GPRC5D BiTE and daratumumab. And finally, you heard beautifully from Michael a minute ago, but you know, bispecifics I think are going to be old hat pretty soon because we're going to have trispecifics. We don't have any CAR T cells without any co-stimulatory molecules. And so on the left is an example of U266 myeloma, or RPMI-8226, where you have actually CD28 here added in, and it's targeting CD38. And you can see augmented activity in the blue line with the tri-specific T cell engager. And on the right-hand side is a tri-specific NK cell engager, where you have CD16 and NKp46 on the NK cell, and could be antigen that you might want, CD38 or others, on the tumor cell. And you have augmented activity. This actually worked was actually done in a lymphoma model. So I've tried to go through this big list pretty quickly. I think the microenvironment is still important and we can understand the mechanisms of the sequelae of the interaction. I think we need to understand better what we're actually doing to patients with the drugs we use now. And we're particularly focused on this immunogenic cell death and how to induce it, because I think it could, I hope, overcome some of the genetic chaos. I mentioned new targets in the tumor microenvironment and interaction. And then I tried to say, if there is a future for targeted treatments in our disease, I think it's going to be in the context of overcoming or restoring resistance, restoring sensitivity, overcoming resistance to some of our agents. And then just a few thoughts of how the next generation of CARs or BiTEs might be even more exciting than those we have today. So in the future, I think we're going to use quadruplet therapy that you heard about here, high MRD negatives. We're already doing this. CARs and or BiTEs will be compared, and we'll do two things. We will get long-term disease-free survival by doing what? By using or achieving MRD negativity, but also importantly, restoring host anti-myeloma immunity. And if that can happen, these patients will be free of disease and off therapy. And I wanted to just close with this study or this book, Enrique. I don't remember what year you were with us exactly, but this was in 1986. And this is, Francesca Thompson was the first patient that ever got an autologous transplant at Dana-Farber. And she was an orthopedic surgeon. And she actually wrote a book about her experience. It's called On the Right, Going for the Cure. It was condensed in the Reader's Digest and it went all over the world and it increased cancer awareness and also myeloma. But why I'm telling you this today is she and I would go and give talks to caregivers or to patients, and she talked about bone disease and myeloma, and I talked about myeloma, and people were interested in her talk and not so interested in my talk. But in any event, somebody asked her one day, you wrote a book called Going for the Cure. How are you going to know that you're cured? And she said, as I wrote up in the upper left here, cure is growing old and dying from something else. And I think from this course that you've heard over the last couple days, you know, this is happening more and more in myeloma already, but I hope everyone who has been able to listen in is even more excited that honestly a potential cure for many patients is on the horizon. So I think I'll stop here and thank you ever so much.
Thank you very much, Ken. I think it's better not to have questions really. No, we will have, because this is a great end for all the presentation, but definitely we can have. I was there in 2006. So with Paula, in fact, with Marc, that was also here. That was 20 years after the book. So really,
those were the best years.
Yeah, that was amazing. So that was a great overview of how you, and I think we are all trying to search for the Achilles heels of multiple myeloma. One general question for you, Ken, is you have spoken a lot about immune system, and even P53, there is the regulation or impairment of the inclusive with the GABA-RAP and also the degronimide. So many of these strategies are targeting the immune system. What do you think about chemotherapy? Could this disappear from the field of myeloma and move to this targeted therapies and then immunotherapy or not? What do you think about that?
I don't know. I don't know the answer, Enrique. I think, you know, I'm still very much seeing patients a lot, and many of them are still getting transplanted, which I believe is a standard of care. And I do not think we should change that until we have good evidence that we're outside of protocols, but good evidence we are really making a major difference. I think, you know, if it were possible, I think it would be nice to avoid chemotherapy. You know, Dr. Kyle taught us all with low-dose melphalan and prednisone that you get secondary cancers. We all learned that, and those of us who still do transplant, we still have, and I showed high doses, you know, 13,000 mutations after relapse transplant. So if you could avoid that, it would be very important to do so. I think the other reason that I think it's likely over time that chemotherapy will be downplayed is that this high risk idea that I showed you, I think if the immune system is the only way, it seems to me, that we can overcome the constitutive and the ongoing DNA damage, genomic evolution that occurs that underlies relapse or that might be related to melphalan-2. But the point is, I think we can exploit the natural immune system and hopefully restore the immune system and at least return to MGUS or some earlier phase, if not getting rid of the clone entirely. So.
Perfect. Okay, with that I think we can close. Thank you very much, Ken, for the excellent presentation, for being with us. Also, I want to thank all the speakers that are still, some of them are still with us here, and of course the attendees that we have been with these long 2 days of speaking about myeloma, with as you can see, with a very interesting and very hot topics of multiple myeloma, and of course the sponsors that we know we spoke with yesterday, and you have Janssen and Sanofi, GSK, and Pfizer. And we hope we can repeat that next year, and we have said before, in person here in Santander. That would be great, and it would be very interesting to do that. So thank you very much, everybody, and have a nice rest of the day.